السلام عليكم.
وعليكم السلام دكتور لطفي. احنا عايزين بس نبدأ الساعة 4 بالظبط. نعم.
ايوه بس I couldn't share the screen. I couldn't share the screen.
طيب I will stop sharing من ناحيتي. حاضر. حضرتك تقدر تعمل شيرنج من ناحية حضرتك دلوقتي.
You see my slides?
اوكي كله كويس يا دكتور لطفي. صوت حضرتك واضح والسلايدز مظبوطة، ما فيش أي مشكلة. ممكن نبدأ دلوقتي. السلام عليكم ورحمة الله وبركاته. أهلا بكم في اليوم الثاني من المؤتمر السادس من مستشفى السعودي الألماني للأمراض الباطنة. إحنا النهاردة في اليوم الثاني عندنا 2 sessions. السيشن الأولى اللي هنبدأها دلوقتي هتكون نفرولوجي سيشن، والسيشن الثانية هتكون بالمونولوجي. Welcome all the attendants. I am really grateful that everyone is here for us for the second day. Today we have 2 sessions. The first session will be a nephrology session, and the second session will be pulmonology. Assalamu alaikum. Sorry for the interruption. I have interrupted network in the other computer. Today is the second day. We will start with nephrology session. We will have our eminent speaker, Dr. Lotfi Al-Korbi. I am so grateful for Dr. Lotfi to join us for the 6th time. Dr. Lotfi started with us since the beginning, and he's always supporting us. Dr. Lotfi today will talk about diabetic kidney disease and home hemodialysis program. Dr. Lotfi Al-Korbi, he is a consultant and director of nephrology section and hemodialysis unit in King Faisal Specialist Hospital and Research Center. Thank you, Dr. Lotfi, and we will enjoy with you your presentations. Then we will go to Dr. Yahya for his presentation about peritoneal dialysis.
Okay, thank you, Dr. Ahmed, and I would like to thank all the organizers for the inviting me in this conference to give 2 presentations. My first presentation is going to be about a diabetic kidney disease. and we have 30 minutes, and I will try to finish on time, inshallah. Okay, so diabetes is a highly prevalent disease with, and you can really see here that this graph showing the prevalence of diabetes. And the blue bar is in the male, and in the green one is in the female. And as you can really see that as we age, the prevalence of diabetes is really increasing. And for those patients who are above the age, or for those people who are above the age of 65, the prevalence of diabetes is almost 20%. Now, why are we really having a concern from the diabetes? Diabetes is really is the most common risk factor for a cardiovascular disease. This is a registry which was done by Dr. Raushani, and he looked at a Swedish registry, and he compared diabetic patient with type 2 diabetes and those cohort with non-diabetic patients. And he looked at 4 endpoints here. And the first one on the left is death from any cause. And you can really see that the patient with a type 2 diabetes is in the blue line, and those without diabetes or the matched control in the red lines. And you can really see that death from any cause is higher with the diabetes comparing to the non-diabetes. In B is death from cardiovascular disease. You can really see it is also higher in diabetes than non-diabetic, as well as if you look at graph C, which is death from coronary heart disease, is also more common in diabetes than non-diabetic, and hospitalization for cardiovascular disease is common in diabetes than non-diabetic. So diabetes is a common risk factor for major adverse cardiovascular events. So we know the complication of diabetes. We have a microvascular complication and macrovascular complications. Retinopathy, neuropathy, nephropathy as a microvascular complications, and we have cerebrovascular disease, peripheral artery disease, as well as coronary artery disease as a large vessel complication of diabetes. Type 2 diabetes is really contributing to 50% of patients with type 2 diabetes is going to develop a diabetic kidney disease. This is more common than those patients with type 1. So it is common, is almost half of the patient with type 2 diabetes is going to develop CKD during their course of disease. And we know that this is the most common cause of chronic kidney disease worldwide, diabetes, although we have other causes of chronic kidney disease. As you can really see that diabetes is the most common, but also we have hypertension, glomerular disease, and other diseases that can cause chronic kidney disease. But the predominant cause is diabetes worldwide. This is the natural history of a patient with a diabetic kidney disease, and this is specifically true for a patient with type 1 diabetes. You can really see from in the left side is that early on when the patient developed diabetes, and in the right side when the patient developed a renal failure or dialysis. So the first abnormality will be a hyperfiltration, and this is usually missed because there is no abnormality you see in the urine analysis, and you don't really see any abnormality in the serum creatinine, and is the only abnormality maybe decrease in the serum creatinine, which is it will be overlooked. The second thing is the albumin urea, whether it's a microalbumin urea or macroalbuminuria. We start to see a patient with type 2 diabetes after years from the diabetes, they may develop proteinuria. And then, of course, we will start to see a drop in the GFR or rise in the serum creatinine. And finally, the patient may progress to a kidney failure. Is this natural history true for all the patients with a type 2 diabetes? And the answer is no. And how do we know that? This is the UK BDS trial, and this is a 15 years follow-up of this trial. And they looked at those patients who developed albumin urea, as only 40% of the patient with type 2 diabetes who are followed from UKBDS trial, they have albumin urea. And 30% developed a low GFR, or what we will call chronic kidney disease by low GFR. And 60% with CKD did not have preceding albumin urea. So there are 60% of the patient with diabetes, they directly progress to a low GFR without going through the micro or macro albumin urea. This is really also was looked into many registries data from Enhance, Nephron, Riyadh, and other. And they looked whether that all the patient with type 2 will go through microalbuminuria, proteinuria, and low GFR. And I just want you to look into these circles. The blue one is those patients with albuminuria, and the yellow one is those patients with a GFRs below 60, or they have a significant kidney disease with a GFR below 60. Now, those are a patient who's having a chronic kidney disease. And you can see that the blue circle that, yes, there are the majority of the patients, they do have albuminuria or proteinuria. And a large number of them also, they will have combined low GFR and proteinuria. But there are a percentage of the patient who's having low GFR, but no albuminuria. So here is 9%, 4%, 10%, but it's, and here is 10%. So there are some patients with type 2 diabetes, they will just have from normal serum creatinine to a high creatinine or low GFR without going through the micro or macro albuminuria. So we know that diabetes is the most common cause of chronic kidney disease, but there are other diseases that can cause kidney disease in a patient with diabetes. So this is the graph showing people with diabetes, and this is patient without diabetes. So in the diabetes, still diabetic nephropathy is the most common cause of chronic kidney disease, but also hypertension could be the cause, ischemic nephropathy could be the cause, or other causes of kidney disease like glomerulonephritis could be the cause of chronic kidney disease in patient with diabetes. So diabetic kidney disease can lead to end-stage kidney disease, as well as it can also cause cardiovascular disease, and both end-stage kidney disease and cardiovascular disease are a risk factor for each other, and both can increase the patient morbidity and mortality. So how can we manage a patient with diabetic kidney disease? Now, I have to say that 20 or 30 years ago, the treatment of diabetic kidney disease was only by strict glycemic control and blood pressure control. So strict glycemic control, as we know in type 1 and type 2 diabetes, it decreased the microvascular complication, neuropathy, retinopathy, as well as nephropathy. This was also true with blood pressure reductions below 140 or over 90. It's also showed to be arenoprotective in the patient with diabetic kidney disease. However, only doing strict blood glycemic control and blood pressure control didn't really help us a lot, since a large number of the patients still progress to end-stage kidney disease or die from cardiovascular disease. So in 2001, there were 2 landmark studies in patients with type 2 diabetes, and this has really changed the treatment of type 2 diabetes by using angiotensin receptors blockers. One is called Renal Trial, and the second one is called IDNT trial. Both of them, one is used losartan, and the other one used irbesartan in a patient with type 2 diabetes. So what did this trial show? Now, first of all, those trials, they targeting the hemodynamic effect of blocking the renin angiotensin aldosterone system. As you can see, in the left side is a normal nephron, and on the right side is the nephron in a patient with diabetes. And as you can really see that those patients with the diabetes, they're really having a high or activation of renin angiotensin system, and this will increase the angiotensin 2, and this will lead to vasoconstriction of the efferent, as you can really see here. And if the efferent is vasoconstricted, then the intraglomerular pressure is going to increase. So the theory behind giving the ARB is to relieve this obstruction by removing the vasoconstriction or vasodilate the efferent, which will decrease the intragranular pressure, and this will protect the nephron and the kidney function as a whole. So this is the Reynalds trial, which is published in 2001, almost 2 decades from now. This is trial in a patient with type 2 diabetes, around 1,500 patients with CKD. Their serum creatinine is 170 micromole per liter, and or this will be around 1.6 milligram per deciliter. And they also having albumin urea with around 1.2 gram of protein in their urine, and they compared losartan with placebo. So whether losartan is really having renal protection or not, and they looked at the primary endpoint of this study, which was doubling of the serum creatinine in stage renal disease or death. And as you can really see from this graph, that using losartan, it did decrease the primary endpoint by 16%. So this was a positive trial, and that was also duplicated with another trial, which is the IDNT, in the same journals, in the same month. But in this study, they used a different angiotensin receptor blocker, which is irbesartan, and it showed the same, that irbesartan is really having a renal protection effect by decreasing the primary endpoint in a patient with type 2 diabetes, which is doubling of the serum creatinine in stage renal disease or death. Now, from 2001, the treatment of diabetes changed. That, you know what, in addition to glycemic control and blood pressure control, we really have to add RAS blockade with a patient in patient with type 2 diabetes, and this was the standard of care. But however, that was good, but still that there is a large number of the patients still progress to end-stage kidney disease and still having a high prevalence of MACE or major adverse cardiovascular events. So this is wasn't really satisfactory. And as you can see that although losartan was better than the placebo, but the risk is still significantly high of progressing to end-stage kidney disease. So it sounds that we really need more studies and more drugs trying to help to retard or delay the progression of chronic kidney disease. Many trials came after renal and IDNT, Nephron D, Altitude, and On Target. They're trying to combine the RAS blockade angiotensin converting enzymes inhibitor with angiotensin receptor blockers, and all the studies were negative, and some of them in fact showed a harmful effect. And after these studies, the combination of ACE inhibitor or ARB was contraindicated in a patient with type 2 diabetes. So these trials were negative. It was not until 2019 when we started to see another positive studies, and here is the Credence Trial, Sunnah Trial, DABA CKD trial, and lately Fidelio DKD trial. So this is the trials that I want to focus on. Some of them that although they were using the anti-diabetic medication, and this trial is SGLT2 inhibitors, and those are the trial that the primary endpoint was cardiovascular endpoint. But what we get from these trials, when they looked at the renal endpoint, in these trials, they found that those SGLT2 inhibitors also have some renal protection. So it was in most of the studies, it decreased the progression of chronic kidney disease, decreased albumin urea, and end-stage kidney disease. However, those studies were mainly cardiovascular trials. And the mechanism how SGLT2 inhibitors delay the progression of chronic kidney disease is by blocking the sodium glucose transporter in the proximal tubules. So here is the nephrons, this is the glomerulus, proximal tubule, distal tubule. And you can really see that in the proximal tubule, there's a receptors for sodium glucose transporters. And if this receptors is blocked by SGLT2 inhibitors, glucose and sodium is going to be delivered to the distal tubules, And with this distal tubules in the macula densa, it will sense that the sodium is increasing, and with this, that there will be a decrease in the afferent arteriole flow, and this will decrease the intraglomerular pressure, and this will also protect the kidney as a long term. So SGLT2 inhibitors now becoming or change the therapy of a patient with diabetic kidney disease. And the two main mechanisms is natriuresis and glucosuria. So by natriuresis, there will be blood pressure lowering, the tubuloglomerular feedback that I just explained to you, and also the amelioration of volume overload. And this will decrease the intraglomerular pressure, and this is going to have a renal protection. At the same time, they're also having cardiovascular protections. And we know that by causing glucosuria, there could be glucose control and weight loss. This is the only reasons how those drugs protect the kidney and the heart. There is also other possible mechanisms by decreasing the oxidative stress, decreasing the fibrosis, and as an anti-inflammatory effect. So those three landmark studies, which were mainly cardiovascular outcome trials, unfortunately, the patient who have a chronic kidney disease or proteinuria were minimal. So they were not really representing whether these drugs are beneficial or not. Not until the 2019, when the landmark study called Credence Trial was published. And this trial looked at the patient with type 2 diabetes, 4,000 patient or 4,400 patient with type 2 diabetes and chronic kidney disease, and their GFR is below 90, is ranging between 30 to 90 ml per minute, and they also having around a gram of albumin urea. So this is a classic patient with a diabetic kidney disease. Now, all those patients on the drugs, which is the first line of therapy, which is RAS blockade. So 100% of those patients were on RAS blockade, and they compared those patients with, by using canagliflozin here in the green with the placebo. And they found that those patients who used canagliflozin as SGLT2 inhibitors decreased the primary endpoint, which is end-stage kidney disease, doubling of the serum creatine, death from renal or cardiovascular disease now. So this trial showed a positive effect of SGLT2 inhibitors on the renal endpoint in a patient with type 2 diabetes. As you can really see here, that the here canagliflozin reduced the primary endpoints. And from that date, SGLT2 inhibitors were added as a drug to really an anti or a hypoglycemic agent that have a renal protection. So in addition to glycemic control, blood pressure control, RAS blockade, SGLT2 inhibitors were added from 2019. Now, since we're talking about anti-hyperglycemic medications, this is about the GLP-1, and this is a leader trial, which is also looked at a patient with type 2 diabetes and whether GLP-1 will also have a renal protection similar to the SGLT2 inhibitor. And although the study was positive, but the primary or the main driven to this was by decreasing the microalbumin urea. So the GLP-1 reduced the microalbumin urea, but we don't really having an evidence that is also decreasing the progression of diabetic kidney disease. But it should really be used as a second line if we don't have SGLT2 inhibitors, or in addition to the GLP-1, in addition to SGLT2 inhibitors, if blood sugar is still not controlled. And the recommendation is in those patients with a GFR is above 30, with a diabetic kidney disease, SGLT2 inhibitor should be the second line of drug after metformin if the GFR is really allowing that, as we know that those medications should only be used if the GFR is above 30. Now, that trial is really make us thinking that those medication may help as well in those patients with non-diabetic kidney disease. And the DABA-CKD trial took a patient who has no diabetes. They used SGLT2 inhibitors in a patient with diabetes as well as with no diabetes. So this is another 4,300 patients with type 2 diabetes, and they also having proteinuria, and they are having a high cardiovascular risk, as again all of them on RAS blockade. And they compared dapagliflozin, which is an SGLT2 inhibitors, with placebo. And this trial has also a number of patients who have no diabetes, so including a patient with diabetes and without type 2 diabetes. And the primary endpoint was sustained decline in the estimated GFR of at least 50% in stage kidney disease or death from renal or cardiovascular death. And this trial also was a positive trial that showed that using SGLT2 inhibitors, here is another drug called dapagliflozin, also decreased the primary endpoint. But the most interesting point of this trial, that there is a big number also who are not diabetic. So this is really good to know that 1/3 of this trial were not diabetic, and this drug was also effective to be used in a patient with kidney disease, even if they are not having diabetes. Now, we know that the safety of SGLT2 inhibitors is it has a hemodynamic effect like the ACE or RAS blockade. So in the first few weeks, there will be a drop in the GFR, but as a long term, the GFR will be better. So this is really the placebo. You can really see that once we start SGLT2 inhibitor, we're expecting the GFR, they may drop by 4 to 6 ml per minute. However, if you really look at the long term, you will find that those patients on SGLT2 inhibitors have a better GFR than those patients not on SGLT2 inhibitors. Important point to mention that there is no difference in the amputation or fracture, which were reported from previous cardiovascular trials, and there is no hypoglycemia in those patients who do not have diabetes and they are on SGLT2 inhibitors. Other trials, so we talked about the Credence and we talked about the DAPA-CKD trials. There is another trial called Sunnah Trial, and in this trial they used endothelin receptor antagonist, and we know that in this trial they used atrasentan, which is endothelin receptor antagonist, and this is as an anti-inflammatory and anti-fibrotic drug. And the trial called Sunnah Trial. The problem with this trial that we know that endothelin receptor antagonist having a side effect, which is a fluid retention. So to do this study, they started with the enrichment period, where those patients who develop a side effect from the atrasentan, they exclude them from the study. So they started with 4,000 patients, and only those patients who responded by decreasing the albumin urea and no fluid retention, they randomized them to atrasentan or placebo. And it found that atrasentan was also decreasing the primary endpoint, which is the composite of the doubling of the serum creatinine, dialysis, transplant, or death. So atrasentan could be another promising drug. However, it's not yet available, and it has to be used in a selected type of patient that who has no fluid retention after using it. So we really have, whenever it becomes available, that this drug, it may really induce fluid retention in at least 1/3 of the patient. So we really have to observe for this. The last trial is about using finerenone. Finerenone is non-steroidal selective mineral corticoid receptor antagonist, and this is a study called Fidelio Diabetic Kidney Disease Trial. So they used finerenone compared to the placebo. They took around 5,700 patients with type 2 diabetes, and they compared finerenone versus placebo. Finerenone in the blue line and placebo in the red. And those patients, they do have albumin urea, and they also having a CKD with a GFR is below 60 ml per minute, or between 25 to 60 with retinopathy, and all of them are on RAS blockade. So what they looked at as the primary endpoint was a kidney failure, sustained decrease of at least 40% in the eGFR, or death from renal cause. And they also looked at a cardiovascular event as a secondary endpoint. So this, what the trial showed, that using finerenone as a selective mineral corticoid receptor antagonist decrease the primary endpoint comparing to the placebo, which is a kidney failure or decrease in at least 40% drop in the GFR. And this is the secondary endpoint, as we know that finerenone is also cardioprotective, and it showed that also decreased the secondary endpoint, which was death from cardiovascular cause, non-fatal myocardial infarction or non-fatal stroke or hospitalization for heart failure, although this was predominantly caused by decreasing the hospitalization for heart failure. And after that, and since 2020, we know now that we have many drugs that can delay the progression of a patient with a diabetic chronic kidney disease, glycemic control, blood pressure control, RAS blockade, SGLT2 inhibitors, GLB1 receptor agonist, atrasentan as endothelin receptors, endothelin 1 receptor antagonist, and finerenone as a non-steroidal selective mineralocorticoid receptor antagonist. And with that, I would like to thank you for your attention, and I would be happy to answer any questions. Thank you very much.
Thank you, Dr. Lotfi. We really enjoyed this presentation. Let me check on the questions. First question, can we use SGLT2 inhibitors in diabetic patients whom diabetes is well controlled with diet and metformin only, just for the sake of prevention of diabetic kidney disease?
Now, the FDA approved SGLT2 inhibitors to be used in diabetes only, although we do have a patient who are not diabetic and they are also an SGLT2 inhibitor, but this is off-label now. Till now, we don't really having an approval to be used in non-diabetic patient. So if it's going to be used, it is off-label. The FDA approved it only to be used in a patient with type 2 diabetes.
This is clear. Thanks for your answer. So patients who are not diabetic may benefit from SGLT2 inhibitors, but this is off-label. But if I have a patient who is diabetic and his diabetes is well controlled with diet and metformin, can I add SGLT2 inhibitor just to protect his kidneys, or this is enough?
Yes, the answer is yes. Now, if you really go to the American Diabetic Association, now they're recommending that those patients who are at a risk of atherosclerotic cardiovascular disease or heart failure or a diabetic kidney disease, they're recommending them to be started on SGLT2 inhibitors. And I think if you have a patient with type 2 diabetes, I think that we should not really be reluctant to start them on these medications. Those are proved that these drugs are not only renal protective, but cardiovascular protective. And this is really evidence-based and approved by the American Diabetic Association and
approved
other agencies.
But not yet approved here in Saudi FDA.
Which one?
Using SGLT2 inhibitors in non-diabetic patients.
I think it is used from the I think the Endocrine Society. They approved to use SGLT2 inhibitors in a patient with a diabetic kidney disease who is at a high risk of cardiovascular or chronic kidney disease.
Okay, very good. From your experience, if I have a diabetic patient and he has established diabetic kidney disease, and I have to add one drug, which to choose, GLB1 agonist or SGLT2 inhibitors?
Now, if we always look at what is the evidence. Now, if we really look at the international agencies' recommendations, they're recommending for any patient with chronic kidney disease or heart failure, the priority is SGLT2 inhibitors, because those are the main benefit of SGLT2 inhibitors. If the primary problems with the patient is only atherosclerotic cardiovascular disease, you can use either GLB1 or SGLT2 inhibitors. So you can use either one if it is only atherosclerotic but no heart failure and no kidney disease. But if the patient having a heart failure and or chronic kidney disease, SGLT2 is the priority or the choice.
Okay, it is clear. Thank you, Dr. Lotfi. It was really a very nice presentation. We will wait for you after 30 minutes after Dr. Yahya will present his presentation about peritoneal dialysis to know more about home hemodialysis. I am sorry, we have another question. What most missed teaching to diabetic patients in stress avoidance? I think we can postpone this question. It is not clear. So now with Dr. Yahya Makaya. Dr. Yahya is a consultant in renal medicine in UK. Actually, Dr. Yahya is my senior resident from Ain Shams University, and we have been friends for more than 15 years now, maybe more. Dr. Yahya Makaya is MRCP UK and master degree, PhD degree, MRCP nephrology, mashallah, renal medicine consultant, and peritoneal dialysis lead clinician in Northwest Anglia NHS Foundation Trust. Thanks for joining us, Dr. Yahya, and please start sharing your screen.
Yeah, thanks, Ahmed, for this invitation. I'm really grateful for it. And thanks for the Saudi German hospital as well for letting me present this for you. Can you see my screen now?
Yes, it is. It's shared with us right now, but okay. I think it's better to make your voice louder a little bit.
Okay, that's fine. Yeah, I can.
Okay, it's clear now. It's clear now.
Okay. All right. Thanks for inviting me to this conference. I really enjoyed the previous lecture from Dr. Lotfi. I'm going to speak to you today about peritoneal dialysis. This talk is mainly designed for non-nephrologists who can or will see peritoneal dialysis patients on the wards or in the emergency department in any hospital. So our agenda today will we'll speak about the PD system, PD demographics, PD system and principles of peritoneal dialysis. What are the types of peritoneal dialysis? And the complications of peritoneal dialysis, and the most important complication is the peritonitis, and at last we will speak about the outcomes of peritoneal dialysis. So chronic kidney disease is, I would like to say, it's an endemic or epidemic in the meantime all over the world. So numbers of patients who has chronic kidney disease all over the world is increasing, and it's especially increasing with the age of the population or with aging population. So in this graph from the Renal Registry in 2019, we can see the prevalence of chronic kidney disease, stage 4 and 5, among the general population in United Kingdom, and you can see it's nearly skyrocketing at the end of 65. Above age of 65. And after the patient reaches the chronic kidney disease stage 5, those patients will need renal replacement therapy. So numbers of patients requiring renal replacement therapy, it's increasing, but increasing by time, but it's a slow increase. So it's estimated from the Renal Registry to be increasing by around between 2 to 5%, depending on the geographical area per year. So this can make it around 25% increase about every 5 years. And you can see that the incidence of the of renal replacement therapies increases as well with the age of the patients. This is the prevalence in United Kingdom per million population. So for every 1 million population, there is around, and if we took the figure, the total is around 1,000 or between 1,000 to 1,500 patients, around 1,300 patients on renal replacement therapy every year. This is the curve that shows the distribution of the renal replacement therapies among different modalities. So we can see that the transplant patients or the transplant population are increasing more than other modalities. And it's estimated the peritoneal dialysis population is increasing, but around 2 to 5% per year only. But for the transplant or for the in-center hemodialysis, it's growing more, and even for home hemodialysis, which is the top one. In the meantime, peritoneal dialysis nearly accounts for 5% of the whole renal replacement therapy population in the United Kingdom. If we calculated this figure in the dialysis population, it's around between 10 to 15%, and it's aimed to increase. We are aiming to increase it to 20% of any dialysis program. So let's speak about the dialysis itself now. So what peritoneal dialysis involves? It involves infusing or putting a fluid in the peritoneal cavity of a patient and leave it for some time, and then taking the fluid out. So infusing the fluid, leave it. So infusing the fluid, it's draining in the fluid, leave it, which is called the dwell time, and then take it out. In this type of dialysis, we use the lining of the peritoneum, the peritoneal lining of the viscera and the parietal peritoneum, which lines the abdominal cavity, in order to, as a membrane, in order to transfer the solutes or the toxins or the uremic toxins and water between the blood and the dialysate. So in this figure, we can see this is the peritoneal tube. The peritoneal tube it's coming from outside across the anteroabdominal wall, then enters the peritoneal cavity, and this is the small intestine, and the peritoneum here lines this is the parietal peritoneum, it lines the peritoneal cavity, and the visceral peritoneum lining the viscera or the abdominal organs itself. And this is the fluid that we put inside the peritoneal cavity, and across the peritoneal membrane, exchange happens between the blood, the toxins and the water in the blood of the patient, and the dialysate, or what we can call it the dialysis solution. So if we took the peritoneum itself and look under the microscope about it, and look for it under the microscope, we will find this is a blood vessel, and this is the peritoneal membrane. So we can see that between the blood vessel and the rest of the membrane, if we enlarge this section, we will find that there is a different size of pores lining the endothelium, or creating the membrane between the dialysis solution and the blood. So there are three main types of pores, different in size. So small size pores, which called aquaporins, which accounts between 1 to 2% of the pores, and ultra small pores, which is aquaporins. Small pores, which can the ultra small pores is usually permeable to water. The small pores, which accounts for nearly 60% of the peritoneum, is permeable to the small molecules, like some of the uremic toxins. And the large pores, which accounts for nearly 40%, is permeable to large molecules like the albumin. The percentage of the pores and the distribution of them is different between individuals. And this later on can create, or based on them, and based on the testing of the efficiency of the dialysis and the ultrafiltration rates, we can modify or divide our patient population into 4 categories. Based on it, we will change or we will modify the dialysis prescription. The solutes or the toxins or the water moves across the membrane. So the solutes, like the urea, moves across the membrane either with diffusion or convection. Convection entitles adding pressure to it. However, the water moves across the membrane using osmotic gradient. So it moves from the low osmolarity section or the low osmolarity compartment to the higher osmolarity compartment. This is why in the peritoneal dialysis solutions, we used to put osmotic material like the glucose in order to absorb the water and make it travel across the membrane towards the section of the higher osmolarity, which is the section, which is, or the compartment of higher osmolarity, which contains the dialysate or the dialysis solution. So this is what we were speaking about. So this is the blood vessel, and this is the peritoneal cavity compartment. The glucose is in the peritoneal cavity compartment, creating osmotic gradient. So dragging the water from the blood compartment towards the peritoneal cavity, and on the other, but however, if this glucose stayed in the peritoneal cavity for longer time, it will be absorbed back again to the blood through the small pores, and then the osmolarity will be reversed. So we will lose the ultrafiltration that we created earlier. This is why dwell time of each solution is very important. So what are the factors that affects the efficiency of the peritoneal dialysis? Number one, how long is the dialysis? So if we are performing dialysis for a patient 4 hours a day in comparison to 8 hours a day for another patient, so total, this is if we are performing dialysis for 4 hours a day for a patient and 8 hours a day for another patient, so the dialysis efficiency for the patient who receives longer dialysis duration is much higher. The second thing that can affect the efficiency of the dialysis is the dwell time, and it's related as well to the type of the fluid that we will put in the abdomen of the patient, in the peritoneal cavity. So the dwell time is how long this amount of fluid will stay in the patient's abdomen. Third thing that can affect the efficiency of the dialysis is the blood flow rate. So patients who are septic or who are with hypotensive shock in intensive care unit, so the blood flow to the peritoneum will not be as a normal patient who is living in his house or her house. So the blood flow, when the blood flow to the peritoneum declines, the efficiency of the dialysis will decline as well. Fifth thing is the surface area of the peritoneal cavity that is available for the dialysis. Patients who have previous surgeries in the abdomen and adhesions in the abdomen, their surface area will be reduced, and therefore the efficiency of the dialysis will be affected. The last one is the membrane permeability, the peritoneal membrane permeability, which we mean by the distribution and the number of the different pore sizes that we spoke about earlier. So let's go into, let's leave the physiology now, and let's go into action with the patients. So what are the available types of peritoneal dialysis in the meantime? So in the meantime, we have two main dialysis categories. One called continuous ambulatory peritoneal dialysis, which we can refer to as manual dialysis. And the other one is the automated peritoneal dialysis, which is a machine controlled dialysis. So the difference, nearly 20-30 years ago, there was another type, which is intermittent peritoneal dialysis, but it's rarely used nowadays, which involves putting the patient on something like the 20 or 24-hour dialysis twice a week, but it's rarely used nowadays. The continuous ambulatory peritoneal dialysis, which is the manual one, the patient is doing it during daytime, and it's by infusing the dialysate or the dialysis solution into the peritoneal cavity and leave it for a few hours, then take it out. And the patient do this the connection and disconnection by themselves. The other one is while the patient is sleeping overnight, before he goes into sleep, he or she put the machine or put the fluid on the machine and connect themselves to the machine, and the patient and the machine will do the exchange overnight. This makes it easier and makes it more easier in controlling the in and out, and using the machine we can do this cycle, the in and out, more frequent than doing it by day. So if we are doing the cycles per day, it's usually between 4 to 6 cycles per day, because we need to keep the fluid in the abdomen for some time, and then the patient will take it out. So let's go for a curve that can give us a clear idea about what's happening. So if we started at 10 p.m. at night, the patient puts some fluid in the abdomen and then leave it there, and then by 7 a.m. drain it out and put another one and leave it there. 12 a.m. drain it out and do the same cycle. This patient is doing 4 cycles per day till 4 cycles per day, and do it by themselves. So this is the CEPD. But the APD can be done during while the patient is sleeping, like the second one. The patient went to bed at 10 p.m. and the machine will put the cycle. This is nearly 5 cycles over 9 hours. So the patient dialyzed needed 9 hours, and he had 5 cycles in it, and it's totally controlled by the machine. And the machine in this section will measure how much fluid went in and how much went out, and will calculate all of this. But for the CEPD, it's totally manual. So the patients themselves, they have a logbook and they calculate how much went in, how much went out, and they record it by themselves, and then they show it to us. Sometimes we can combine both together, or we can ask the machine to put a day dwell during the day and leave it there, and then when the patient connect themselves at night, the machine will take it out. So who can have the dialysis, peritoneal dialysis? I will say any patient who wants to have PD should have a PD dialysis, unless there is a very absolute contraindication. And I will label it, I have listed here multiple absolute contraindications, but I will say the absolute contraindication is that the patients in whom the membrane is not working. And if the membrane is not working, it will lead to all these absolute contraindications. So if the patient have ischemic bowel, so this means there's no blood flow to the peritoneal, to the viscera, so then the exchange of the toxins across the membrane will be impaired. So those patients cannot have it. Patients with verticulitis, inflammations, patients with abscess or peritoneal abdominal abscess, or patients with adhesions, those patients have lost significant amount of the peritoneal surface area. Therefore, we cannot do efficient dialysis for them. And there are some relative contraindications, like patients with colostomy or ileostomy, patients with large polycystic kidney, patients who have dementia, or patients who have significant proteinuria. So how can we put the catheter? Who put the catheter in? So it's the methods that we can use to put the catheter is either open surgical, laparoscopic, peritoneoscopic, and cylindrical techniques. The open surgical is rarely used nowadays, and it's done by surgeons. Laparoscopic is done by surgeon, and it involves using the laparoscope, and it's helpful in stitching or suturing the tip of the catheter inside, and ensuring that it's in the pelvis of the patient, and ensuring that it's in the proper position. Peritoneoscopic, it's different than laparoscopic. It involves giving around between 500 to 1,000 cc of carbon dioxide in the patient abdomen and using a small camera to locate to actually ensure that we are in the peritoneal cavity. Then we will put the peritoneal catheter inside. The Sildenga technique, which is very common nowadays, the peritoneoscopic and Sildenga techniques are usually done by the radiologist or the intervention nephrologist. Sildenga technique is very commonly used, and nearly half of the centers in the United Kingdom, the nephrologists are putting the dialysis catheters by themselves using the ultrasound or the fluoroscopic guidance. The catheter, most of the catheters that we use nowadays involve has two cuffs. So this is the catheter that actually I prefer. There's no, in the meantime, there's no preference towards one of the catheter over the other one from the clinical trials. However, we used to use the third one, which is the coiled catheter, because it increases the surface area available for the exchange of the fluid, and at the same time we use two cuffs. One of these cuffs, the inner one, we put it just above the rectus sheath, or just above the muscle of the rectus abdominis muscle, and some of the surgeons, they embed it inside the muscle itself. But embedding the cuff inside the muscle makes it harder for you to take the catheter out in case of any complication. And the second cuff will be in the, we dissect the anteabdominal wall and we put it in the subcutaneous tissue. So what are the dialysis solutions that we use? We use mainly, so we have three types of dialysis solutions that we put in the patients. They differ between each other in the amount of water and osmotic agent and the electrolytes used. There are glucose-based dialysis solutions, which involves usually three concentrations, the 1.36 or 1.5 and 2.25 or 2.5, and the 3.38 or 3.8 this is the highest concentration, and we use it rarely only to ultrafiltrate the patient and take more fluid off from them. The other common dialysis solution is called extraneal, which use icodextrin, which is a polymer of starch or carbohydrate that is not absorbed by the patient, and we use it for long dwells because it facilitates the ultrafiltration and the clearance of the patient, and avoid the drawbacks or avoid the side effects of giving too much glucose for the patients, because many patients will complain from the weight gain that they will have from the glucose, and there are other side effects as well regarding the pH and the glucose degradation products of these materials. Nearly between 2 to 5% of the patients will use amino acid-based solution, in which we put amino acids in the solution as a nutrient for the patients. However, the clinical trials haven't proved strong benefit of using these solutions yet. So what are the complications that we might face from the peritoneal dialysis? The first one, so we have the general dialysis related complications, and we have the specific peritoneal dialysis related complications. The general ones, like the anemia, like the mineral bone disease, like the psychological, many other problems that we will deal with it in peritoneal dialysis patient like any other dialysis patient. But there are some specific complications which we will go through quickly now. So we have specific complications for the peritoneal dialysis, infectious complications, which are entitled to two main categories: the peritonitis and the exit site or tunnel infection. And the non-infectious complications, which involves the impaired flow, either in or out, or one of them, the leaks and the pains. during either infusion or during draining, abdominal pains. Other complications related to the high intra-abdominal pressure, like the back pain, like the hernias, like the hydrothorax, and some complications like the metabolic syndrome and the hyperkalemia, and finally the most serious one is the encapsulating peritoneal stenosis. Very common complication or very common encounter or very common problem that we will face in our peritoneal dialysis clinic and our dialysis nurses will face with the patients is reconstitution. Many of our patients are elderly, so they are more prone for constipation. They are on phosphorus binders, which causes constipation, and they move less, so then they are constipated and they don't eat high fiber diets. Classically, we aim for 2 to 3 bowel motions per day in order to have an efficient drainage from the in and out of the for our dialysis, for our PD system. Sometimes the distended bowel loops in the pelvis will push the catheter up, so we should see the tip of the catheter in the pelvis to facilitate the drainage. But if the pelvis or if the rectum is full or distended with feces, it can push the catheter up and lead to malposition of the catheter. So I will touch quickly on the peritoneal dialysis related complications, but I would like to mention that if you encounter the exit site infection, it should be treated for 2 weeks according to the International Society of Peritoneal Dialysis guidelines. Let's go for the PD peritonitis. So this is the classic, what we say, cloudy bag of the PD peritonitis. The simple test that we use is that we cannot see any letters if we put any paper underneath this bag. So in order to diagnose PD peritonitis, we need to have 2 diagnostic criteria from those 3, either the clinical pain or cloudy effluent. Number 2 is the presence of more than 100 cells per millimeter cubic, and more than 50% of them should be neutrophil or positive culture. 2 of them are sufficient to diagnose PD peritonitis. The source of infection, it could be contamination from touching from the skin or touching the tube itself or the tip of the tube, which is very common from the patients, or extension from exit site or tunnel infection, or secondary to other non-dialysis related from other septic sources in the body. So the main symptoms will be the tenderness. There might be the abdominal tenderness, might be rebound tenderness, and occasional, sometimes systemic signs like frank sepsis can happen to the patient. The patients on automated peritoneal dialysis, they might not have the cloudy bags because we are dwelling especially if they have very frequent dwells overnight, because classically the dwell so it has been approved that we should leave the fluid inside the abdomen for at least 2 hours in order to have a significant result. But some of those patients on APD, we might leave the fluid only for less than an hour, so we can encounter PD peritonitis in them without cloudy bags. For any patient with PD peritonitis, we should swab the exit site as well and do full septic screen for these patients. Antibiotics should be given immediately, as soon as possible, just after taking the samples and without waiting for the culture results, because it's very critical for those patients to save their peritoneal membrane. The longer we wait, the more scarring and the more peritoneal membrane dysfunction that we will face later on. And it's recommended from the ISPD guideline to start with gram-positive and gram-negative cover, as well as antifungal at the same time. It's mainly a clinical diagnosis. Sometimes we need radiological diagnosis, and let's know as well. So we will need radiological diagnosis in case there is a recurrence, a relapse, or refractory or repeat infection. If there is a suspected tunnel infection, then we need to perform radiological investigations. Classically will be the CT abdomen for those patients to localize, to look for infection, tunnel infection, or other septic focuses. Do we need for peritoneal dialysis patients to give prophylactic antibiotics to avoid infections? Yes, in sometimes. So if the patients are undergoing dental, gynecological, or hysteroscopy or colonoscopy, in order to avoid translocation of the bacteria, we should give prophylactic antibiotics. Also, if tube break happens, if there is a tube break in the tube, hole in the tube, if the patient touches the tip of the tube, and during insertion or repositioning of the tube, we should give prophylactic antibiotics based on the center protocol. Each center has its own protocol according to the ISPD guidelines. So here is a case that I had in one of my patients. He's a 61 years old male. He had a hypertension, ischemic heart disease, and type 2 diabetes. He reached end stage in February 2021 and started PD at that time. In April 2021, he reported drainage issue, and this is his X-ray of the abdomen. So you can see that the pelvis is completely clear. There's no, the tip of the cancer cannot be located in the pelvis. And you can see his colon is loaded. And where's the tip of the cancer? Oh, it's up there. It's near the diaphragm in the left hypochondria. So basically, we managed this patient by giving him more laxatives, and it went down again here. You can see it in the pelvis. I'm sorry if the images are not clear for any one of you who is using mobile or other screens. So later on in June 2021, he faced the same problem again, and it moved to the other side. Actually, it moved to the right hypochondrium, and we managed it by laxatives at this time. And we started to discuss with him the doing a procedure to reposition the catheter surgically and fix it in the pelvis. But later, then after a month, he developed this scrotal leak, and we discussed it with the surgeon, and we agreed to perform an operation for him to close the patent prosthesis Reynalds and to have a reposition of the catheter. Actually, we did the total exchange for the catheter by the end of in September 2021, and we started the retraining for the patient, and he was back on dialysis again in October 2021. Then in November, after a month, he developed a cloudy bags, and it was a poster for culture, a poster for staph epidermidis, and was treated with peritoneal dialysis. And at that time, there was no evidence of tunnel infection, and he was managed with IV antibiotics. And just after finishing the course of the IV antibiotic, he presented again to the ED but with abdominal pain, vomiting, and repeated, and even he developed shock. We admitted him to the intensive care unit and started treatment as per CEPTIS protocol. We sent the culture for it was over the weekend, and we sent the culture, we sent the peritoneal dialysis fluid for culture, and it was more than 2,000 white cell count in the PD fluid. And we started PD protocol. On the next day, I saw him in the intensive care unit, and I was not buying this scenario, and his abdomen was distended, and I felt that there's something else ongoing, and there was a hard mass near the umbilicus. So I requested a CT scan for him. Basically, this is the CT that is showing distended bowel lobes. I was searching as well for any evidence of tunnel infection. We can see the tube here. There's no collections around the tunnel. However, in the umbilicus or parumbilical, with the insertion, with the entry point of the laparoscopy that he had in a few months earlier, there was a strangulated paraumbilical hernia that caused for him this picture, and we managed to resuscitate him, and we went into the theater, and he had this hernia occurred, and the P2 taken out, and in the meantime he's on the hemodialysis. This will bring us to the preoperative and postoperative assessment of peritoneal dialysis patients. So as a rule, patients on dialysis will have to check the potassium and the volume state carefully pre and post operative. Patients who is going to have abdominal surgery, patients on peritoneal dialysis who will undergo abdominal surgery classically should stay off peritoneal dialysis for 1 to 2 weeks. If they have significant residual kidney function, more than 5 ml per minute, then they can hold without dialysis at all. If not, then we will need to bridge them using hemodialysis. The available systems nowadays for the peritoneal dialysis, there are worldwide 2 main companies providing the systems for the peritoneal dialysis, but I'm pointing towards the online remote monitoring of the patients now. It's very, very helpful in assessing the patients and anticipating complications and monitoring them, and get in touch with the patients once we have any flags on our systems. I will say the outcome of peritoneal dialysis is not different at all in comparison to other dialysis modalities. It's not either home dialysis or in-center hemodialysis. Still, the transplantation is superior than other renal replacement therapy modalities. But if we compare the peritoneal dialysis to the hemodialysis, we will find they are nearly the same. So this is the curve that shows the mortality from different. So the mortality among the in-center hemodialysis population, and this one is the form PD, and they are nearly the same with cardiovascular diseases on the top of the list as a cause of mortality. In summary, it's a very effective renal replacement therapy. I cannot say there's absolute contraindication unless there is a membrane failure. It requires a good catheter insertion and a good multidisciplinary team to maintain the catheter in place, and patient education is key in dealing with patients with peritoneal dialysis. And most of the time, we leave the choice of the dialysis modality to the patients themselves in order to have it according to their lifestyle. Yeah, I think that's it.
Thank you, Dr. Yahya. It was a really nice presentation. You covered all aspects of peritoneal dialysis, and you exceeded your time by 10 minutes, but thanks to a lot of people waiting for us. We have some questions here raised here. We know that we have an initiative to BD first, to start with peritoneal dialysis for those patients with CKD stage 5 waiting for renal replacement therapy. But for how many years, from your experience, for how many years can we stay on BD?
So if we took the numbers, it's averaging between 3 to 5 years. But centers who have good or low peritonitis rates, the numbers are much better than other centers, because the peritonitis is one of the key factors that limits or that impairs the membrane ability or the peritoneal membrane ability by time. So excellent choice of the patient at the beginning, good education, avoiding using high glucose contents and assessing the patients well, and avoiding peritonitis episodes. And if the peritonitis episode happen, to intervene early with it, this will save the peritoneum and actually save time for the patients to go on dialysis, to stay on peritoneal dialysis for longer time till they have a transplant.
Okay, in your unit, do you have an experience with hybrid techniques like doing peritoneal dialysis and hemodialysis in the same time for the same patient?
So we do it on a case-by-case basis, and
Okay.
it's mainly for ultrafiltration for patients with failure.
Yes, exactly. Yes.
So the patient that I mentioned in my case, during his peritonitis episode, he had ultrafiltration failure. So we had to give him one session per week in order to maintain his volume state. So especially during infection episodes, you might find ultrafiltration failure.
Okay, I asked this
But
question
from
because
the beginning, we don't use it as a routine, but we use it mainly till we perform the training of the patient. So in the meantime, I have another patient who had her PD tube inserted in November, but she was in hospital at the time for multiple medical problems, and we had to start because we couldn't. So we inserted the peritoneal dialysis tube, but we couldn't train her or her family for the dialysis. So we had to start her on hemodialysis. In the meantime, she's still ongoing on peritoneal dialysis, and her training is still slow. So training, usually, in order to give the patient the proper training, you need at least 2 weeks of uh, coming to the hospital regularly and assessing the patients and the family and all of this. So during that time, if the patients require actually to start dialysis, we will start on hemo and at the same time put the tube in and perform the training.
Okay, I just asked this question because I attended a presentation, I think maybe more than 5 or 6 years ago, by Professor Lucatelli from Italy. I know that you know him very well.
Yeah.
And he was talking about people with end-stage renal disease living away from the hospitals. He's doing peritoneal dialysis for them in their homes and on and off hemodialysis whenever they need in the hospital.
Yeah. So yeah,
maybe
we have few patients like this, but as I mentioned, it's a case-by-case basis, and it's mainly for ultrafiltration. And we have another. So for those patients who live far away and who are unable as well to perform the dialysis, we have another program which is assisted APD. So instead of the patients doing the connections by themselves, one of the healthcare assistants will visit the patients at their home every day, and they connect the patient to the machine. And in the next morning, they will go and some of them, the patient will disconnect themselves, and some of them, the healthcare assistant will go and disconnect the patient as well.
Many solutions for renal replacement therapy. Thanks, Dr. Yahya, for joining us today. And we are apologizing to Dr. Lotfi for letting him wait for 15 minutes, I think. Dr. Lotfi, are you with us? Dr. Yahya, please stop sharing from your side. Dr. Lotfi?
Yes, I'm with you. I just want to share my slides.
Okay, you can start sharing right now. Now we are with the second presentation for our eminent speaker, Dr. Lotfi Al-Korbi, about home hemodialysis. And
I couldn't really share.
Okay, you can start again. I think Dr. Yahya stopped sharing already.
I need to stop because it's my last presentation. I need to
take your time. Take your time. Yes, we start seeing your screen right now. Okay, thank you, Dr. Lotfi. You will start now. We can't hear you yet.
Yes, do you hear me now?
Well, yes, everything is clear, the presentation and your voice. We
Okay,
can start.
so this is, thank you very much again, Dr. Ahmed, and thanks for the organizers for the invitations. And in the next 30 minutes, I'm going to cover the home hemodialysis. We just listened for the excellent presentation about the peritoneal dialysis, which is home dialysis. But in the next 30 minutes, we're going to talk about home hemodialysis. Okay, so end-stage renal disease is a prevalent disease, and you can really see that this is worldwide, that the number of people needing renal replacement therapy is high, and this is ranging from 100 to around 700 patient per million population. Now, if you really want to look at the data in Saudi Arabia, this is from the Saudi Center of Organ Transplantation. This is the dialysis population in Saudi Arabia. You can really see that the incidence is around 132 patient per million population, and the prevalence is around 631 patient per million population needing renal replacement therapy. Now, this is projected to 2023. And as of today, we are having around 23,000 patients on renal replacement therapy. And we're expecting that by 2023, that we're going to have around 28,000 patients needing renal replacement therapy. Now, patient with end-stage kidney disease having a high mortality, and this is a data from United States, showing that the 3 years mortality is almost 50% of those patients on dialysis. And if you really look at the death per 1,000 patient years, and you look at or subclassified by ages, you can really see that that patients who are older, above the age of 65, is more likely to get death or to die from end-stage kidney disease comparing to the younger population. Now, why those patients with end-stage kidney disease, they die? The most common cause of death is a cardiac disease, and those are the most common cardiac diseases. Almost 40% of the patient or the cause of death in end-stage kidney disease is from cardiac, whether it's an acute myocardial infarction, congestive heart failure, arrhythmia, other cardiac or cardiovascular disease. Other causes of death could be infection, malignancy, or withdrawal from the dialysis. Now, it's not a surprise that coronary heart disease or heart disease is the most common cause of death in a dialysis patient, since heart disease is common in the majority of patients on dialysis. So 80% of the patient on hemodialysis, they're having some source of cardiac dysfunction. And this is just a graph that will show you that the heart in a patient not on dialysis. And if you really compare this to the patient who is in dialysis, you will really see that enlargement of the ventricles and atrial. There is also atherosclerosis, and there is also fibrosis and thin of the wall of the ventricles, left ventricular dilatation, and you can even see some calcification here. Those are complications of a dialysis. You see it in a patient on hemo or peritoneal dialysis. Now, how can we improve the survival of a patient on renal replacement therapy? This is one important study which was published 2 decades from now, 2002. This is called the HEMO study. And they looked to patient on hemodialysis and whether if we really increase the clearance or increase the dose of the hemodialysis, can we improve the survival of those patients? Say they compared the patient with standard clearance, which is they measure it by a method called single pool KT/V, which is 1.3. They compare them to a patient with a higher clearance, and they measure it by a single pool KT/V 1.7. And unfortunately, they found that there is no difference. So the survival did not improve by just increasing the clearance of a patient on hemodialysis. So this left us with many things. What should we do? How can we improve the survival? We started using low flux or moving to a high flux from the low flux, using hemodiafiltrations, using increasing frequency, or doing home hemodialysis. All of this is trying to see if we can really improve the survival of a patient on renal replacement therapy. So one of the major changes in the dialysis is a new paradigm, which is really moving away from clearance and looking at other parameters that can improve the survival of a patient on dialysis, managing the hypertension, focusing on left ventricular hypertrophy, heart failure, preventing intradialytic hypotension, and also focus on the fluid therapy that minimize the cardiac stunning, improve stability during treatment, and minimize post-treatment fatigue. Now, this is what we always see, or what is always in our mind, that this is looking at mortality, which is cardiovascular and all-cause mortality with ultrafiltration. And we know that during the dialysis, we always remove fluid from the patient. The question is that how much should we remove? And we know from this graph, the higher the ultrafiltration, the higher the cardiovascular and all-cause mortality of the patient. And we know that once we exceed 10 ml per kg per hour during the dialysis, we are going to see a significant increase in cardiovascular and all-cause mortality. And this is the challenge with the conventional hemodialysis, which is 3 times per week. That this is when you do the dialysis, the pre-dialysis volume is high, then post-dialysis it goes down, pre-next dialysis goes up. So it is really up and down on the fluid. And with all of this, we rarely achieve the optimal fluid balance in those patients. And that's why those patients will have hypertension, will have left ventricular hypertrophy, and the consequence of that is a cardiovascular event. This is one of the landmark studies that looked at the frequent hemodialysis in a patient with end-stage kidney disease, and it showed that they looked at a surrogate marker, which is left ventricular mass, and they found that those patients with more frequent dialysis, 5 to 6 times per day, they have a better or a lower left ventricular mass compared to those patients with conventional dialysis. So this is really giving a hope that, you know what, with more frequent, you're going to have a better survival of those patients. So what is the advantage of the frequent hemodialysis session? It's more physiological in solute and fluid removal, improvement in blood pressure control, reduction in left ventricular mass, lower ultrafiltration rate, and better hemodynamic stability, better control of phosphatemia, and avoid the long interdialytic interval. Very important. Now, I just want to focus on 2 things: advantage of more frequent hemodialysis, and I mean by frequent is more than 3 times per week. So anything more than 3 times per week is called frequent hemodialysis, 4, 5, or 6 times per week. So I want to focus on the ultrafiltrations and avoiding the long interdialytic intervals. So this is the fluid that we know that this is when the patient leaves the dialysis unit, he will accumulate the fluid, and this will leave him with uncontrolled hypertension, left ventricular hypertrophy, heart failure, hospitalization, and death. However, if we also try to remove a lot of fluid, high ultrafiltration, because this is only every other day dialysis, then we may induce intradialytic hypotension, and this will lead limit use of cardioprotective medication, cardiac stunning, and patient may have really long post-dialysis recovery time because of the cramping and poor quality of life. And this is about the long interdialytic interval. We know that usually between the dialysis, there are 2. This is the 3 dialysis, first, second, and third. And you can really see between the first and second dialysis is 48 hours. and then another dialysis after 48 hours. But the third dialysis session is after 72 hours. And here in this study, they found that those patients who is really staying more than 48 hours, having a higher mortality because of this long dialytic interval. So home hemodialysis in Saudi Arabia, this is a frequent dialysis, hemodialysis at home using a portable next stage machine. And this is a nurse-assisted hemodialysis. This is a unique program, differs from the program in Europe or US, that it's done by the patient himself. Here's the program is by a nurse. That's why it's called nurse-assisted hemodialysis, and using a portable machines. And this is the one available now in the program, which is the next stage machine. So what is the advantage for home hemodialysis? That better survival and better quality of life. And this is any patient with end-stage kidney disease. Whenever we do more frequent dialysis, we're going to have a better survival and better quality of life. But there is also other advantage of doing dialysis at home or home hemodialysis, which is really more convenient for the patient. Which type of patient? Elderly patient. We have a patient with multiple comorbidities that they're really having a difficulty of coming to or going to the hospitals. Difficult in transportation to and from the hospital. Some are bedridden, some needs ambulance, and some of really having a very difficult moving to and from the hospitals. Bedbound or wheelchair dependent. Patient with fractures or amputations, which is really affecting their mobility and will make their transfer to the dialysis unit is difficult. Patient with stroke. A pregnant patient who really need more frequent dialysis may not be possible to do it in center. Sometimes for a family support, patient with cancer, patient with psychiatric disorders, or patient who's really needing a home healthcare service. So those are also advantages for home hemodialysis program. Now, this is the percentage of patients who missed hemodialysis. If we insist to perform the hemodialysis in the centers, then we may have those patients that I mentioned them, that the hemodialysis at home is more convenient. They will miss some hemodialysis session. And this is from the Dobbs study, and showed that the GCC, including Saudi Arabia, is the second most common after the United States patient not coming to the dialysis unit or missing some of the dialysis session. So we're really having a data that some of our patients, they don't come regularly to the conventional hemodialysis or to the in-center hemodialysis, which is 3 times per week. Now, there are many reasons why a patient is not coming, but one of the reasons could be difficult in transportations. Now, is it easy to do home hemodialysis in Saudi Arabia or in the GCC? Of course, you need training, you need self-cannulation, aseptic technique, and monitoring. This is if the patient is going to do the hemodialysis by himself. Now, this obstacles was resolved by doing the hemodialysis with a nurse. So nurse-assisted home hemodialysis, then you don't really need to train the patient. The cannulation is going to be done by the nurse, and of course, this nurse will be trained to do the dialysis under aseptic technique, and the patient will be under monitoring during the session. The other disadvantage or obstacles for a home hemodialysis that you need construction, plumbing. The quality of the water may not really be good for hemodialysis. The high temperature, we touch in the 50s in the summer, so this is really not ideal for hemodialysis. And of course, sometimes the space limitation, and these obstacles is also where overcome by doing the dialysis with a portable hemodialysis machine with a pre-filled bioregion-free dialysate bag. So those obstacles that will make home hemodialysis difficult in Saudi Arabia, they were overcome by a nurse-assisted home hemodialysis and by using the portable hemodialysis machine with pre-filled bioregion-free dialysate bags. So this is the next stage system, a portable machine. We're using dialysate bags, does not need chiller and does not need portable reverse osmosis. and no electrical or plumbing modification need to be done at home. No significant increase in water or electricity cost. So this is how the machine will look like with the fluid. So the patient will be on a chair or in the bed. The machine will be in the side table, and he will have his dialysis at home. So this is the cartridge that we're using, and this is integrated with integrated filters. We have two types of filter, 172 and 124. And this is how the fluid that we're really using it. This is the content of this fluid, similar to the peritoneal dialysis fluid. This is a bags, 5 liters bag, and this is the content of the electrolytes, similar to the peritoneal dialysis or the dialysate and the hemodialysis. Now, this is the program in Riyadh, Saudi Arabia. So this is the team that doing the home hemodialysis. The program is already started around 4 years ago. And those are, you can really see that those are the cars that will take the nurses from the hemodialysis, or sorry, they're going to take the patient from the office of the home dialysis. They're taking them to the patient, and they perform the dialysis there. And there's always continuous education for the nurses and training, so that they will keep maintaining their skills when they perform this type of therapy. How we do it? What's the typical home hemodialysis prescription? In Saudi Arabia, we're doing it as 4 times per week. You know, the conventional is 3 times per week. Home hemodialysis should be frequent. Most of the time, I would say most of the patient, 80%, they are on 4 times per week. We have a few patients on 5 times per week. We have no patient on 6 times per week. We're doing it for 4 hours. The blood flow is 300 to 400 ml per minute. The dialysate flow is 100 to 200 ml per minute. And dialysate composition, lactate or bicarb. And we target standard KT/V, which is for the clearance of 2 to 2.1, which is internationally recommended. This is the how to calculate the dose. In fact, the next stage system has a next stage dosing calculator. So you just need to put the age, weight, height of the patient, and then the machine can really tell you what will be the appropriate dose of this patient. It will give you the options, and in this you can really see that if you really want 4 times per week, this is the duration, this is the volume of the fluid that you should use, this is the target KT/V, and you can really prescribe the dialysis for those patients. Now, how we select those patients and which patient is ideal for home hemodialysis? Any patient can do dialysis at home, and the only contraindication if the patient is refused, if he has no electricity at home, if he has no one to support him as home, which is no caregiver, of course, and if he has no vascular access. Otherwise, any patient can really involve in the program. So once the patient is accepted in the program, we secure a dialysis access, and we just decide if he needs other care than that hemodialysis, because if the patient needs other care, then he has to be referred to the home health care, so they can to support other than the dialysis care. And of course, the home hemodialysis team will visit the patient to make sure that the home environment is suitable for this form of therapy. And once they're fine, then the patient can start the dialysis at home. This is the requirement for enrollment of the patients. As I mentioned, that the patient has to accept this form of therapy, and he has to have a home visit assessment, and he has to have a well-functioning dialysis access, whether it's a catheter or fistula. Now, this is the checklist that is really needed in the program. So all the patient, the home team, the home hemodialysis team, when they go home, they will make sure that all these settings is really available at home. These are very simple, but they really need to be there so that there will be no obstacles for the treatment to be done. Now, those patients are monitored online. As you heard from the peritoneal dialysis, there is online documentation and monitoring of those patients. The physician, the nurse, of course, is going every dialysis session. The physician will go only once a week to visit those patients or as needed. However, there's a continuous monitoring online as well. And you can really see that how's the medication, how's the dialysis of this patient, and what are the chronic problems of this patient, what is his blood pressure during the dialysis. So you can really monitor the patient even from far. And we can also type or print a report from this program, so that the patient, whenever he needs a report, it can be easily printed. Now, how many patients in the program? As of today, we're really having 90 patients. We were expecting to go up to 150. There are work now to recruit more patients to this program. And however, as of today, is only 90 patients in Saudi Arabia on home hemodialysis program. Now, is there any advantage? Did we really notice changes in those comparing to the in-center? This is the characteristics of the patient in the program. And as you can see, the majority of the patient are elderly. So 66% of the patient on home hemodialysis, their age is above 80 years of age. And we have 21%, their age is from 60 to 79, and only 13% below age of 60. Now, what is the advantage in older patient is flexibility in the dialysis schedule, slow, more frequent for a better volume control, less myocardial stunning, improve the clearance, less restrictive diet, reduce the polypharmacy, reduce the burden of travel to the center, and spend more time with their families, and minimize the risk of hospital-acquired infections. All those are advantages of doing the dialysis at home. Now, this is the patient in Saudi Arabia. The majority of them is really having a permacath as their dialysis access, 68%, as you would expect in those elderly patients. But we have 32% their access is AV fistula, and 63% are female, and 37% are males. Now, when we look at the KPI of those patients, we found them that really more frequent dialysis help them to have a target hemoglobin, a target potassium, target bicarb, target calcium, phosphorus, albumin, and BTH. So all these KPI or all these parameters, they were within the target when the patient were in more frequent or home hemodialysis. This is very difficult to achieve it with the conventional 3 times per week dialysis, and it's not difficult to achieve it with a continuous or with more frequent home hemodialysis. Even the blood pressure medication, if you really look here at the number of blood pressure medications, you can really see that this is before they started in the home hemodialysis program. And I just want you to look at those patients who are on 3 medication in red, and you can really see that those patients on 3 medications, they were 12% before the program, and this was there was no one on 3 medications after starting the home hemodialysis. When you look at those patients on 2 medications, 25 before they joined the program, they decreased to 8% after joining the program. And we have before the starting program, 30% they're not on any medications, and when they join the program, the number of patients not taking blood pressure medication increased to 65%. So this is really just showing that by doing more frequent home hemodialysis, we can really improve the blood pressure and decrease the number of required medication to control this. So this is my last slide showing that the choices of renal replacement therapy is the best choice will be preemptive transplantation. However, if we really decide to do a home dialysis, we have peritoneal dialysis and we have home hemodialysis, and we also still having the in-center hemodialysis, which is a conventional 3 times per week, or daily hemodialysis. And some of the patient may go for conserved non-dialytic care. And with that, I would like to thank you very much for your attention, and I am ready to answer any questions. Thank you.
Thank you, Dr. Lotfi. It was a very nice introduction and the presentation about home hemodialysis. And I think this is the first program for home hemodialysis in the kingdom, right?
Correct.
For me, as a nephrologist, when I first see this machine, it was, I think, in a convention in Abu Dhabi, I was thinking that it may cause insufficient dialysis because the dialysate flow is around 100 to 200, and the dialysate flow in the conventional dialysis at least 500 ml per minute. How do you think about these facts?
That's why I agree with you. This is, if you're really compare it to the conventional, you cannot really do it 3 times per week. This machine was made for more frequent dialysis. So you cannot really use it for 3 times. For 3 times per week, it's going to be insufficient. So that's why we're using it minimum of 4 times per week. So minimum of 4 times per week. And in fact, if the patient is really heavy and his weight above 100, even 4 may not be enough. We're going to use a 5 times per week. So minimum 4, but some of the patient may even require 5 to achieve a good.
According to his follow-up lab, you mean, and his general condition.
Correct.
And it is very nice, but in our experience in Egypt, for home dialysis is making the whole set at home to bring a small water treatment system, and the patient himself will buy the conventional dialysis machine. Do we have this setting, or it is licensed in Saudi Arabia?
I think, you know, that the problem is that the difficulty of, there is no license in Saudi Arabia for the conventional machines. Now, the question is that how difficult is to do a conventional machine. Now, as I said from the beginning, this machine, the portable, in fact, it's really done for the patient to use it. So it's simply can be used by the patient, doesn't really need, you know, excessive training. The second thing is that there is no plumbing, so you don't need somebody to do any construction at home. And the most important that we know that in Saudi Arabia, the temperature goes to the 50, so you really need a chillers, which are really making it very
exactly. We have this problem all the time.
And the quality of the water, so it's not in all area that you will have a good quality of the water. So you really have to have, of course, you really have
filter or chillers. This is the issues all the time.
So this is really making the conventional is very difficult in the GCC as a whole. And in fact, if you really go to the US, more than 90% of the patients in the United States in home dialysis, they are on the next stage. So even there, so they think this is more easier and less cumbersome than the conventional dialysis.
Okay, thank you, Dr. Lotfi, and thanks for giving us these 2 presentations and waiting for sharing these experiences with you next year, inshallah.
Thank you very much.
Thank you. And now, for the first time with SGH webinar, internal medicine webinar, we have Professor Mireille Karavetians. Professor Mireille is a clinical dietitian specialized in kidney disease with a PhD from Maastricht University in Netherlands, and currently working as lecturer in Ryerson University, Toronto, Canada. Thanks for joining us, Dr. Mireille.
The pleasure is all mine. Thank you, Saudi German Hospital, for inviting me, for giving me this opportunity. With no further ado, I would like to start my lecture. Just 1 second.
Okay, please start sharing your screen.
Yes.
Your voice is clear for us, but we didn't see your screen yet.
Okay, 1 second. Yep, all is good.
Everything is clear. Thank you.
Very good. Thank you, everyone, for attending the conference and being patient. I know it is around late afternoon in KSA, and with no further ado, I would like to start my lecture. It is about nutritional management and chronic kidney disease. I'm very passionate about nutritional management and taking kidney disease seriously from all aspects, from the multidisciplinary team, not just the physician, but also the dietitian, the pharmacist, the physiotherapist, the psychologist, because it really takes a village to take care of one kidney failure patient and protect them from any deterioration that happens from the disease. I'm sorry if I would cough from time to time. I'm still recovering from COVID, so sorry for my voice also. Nutritional assessment is very important for a renal failure patient, and it should not be taken lightly. It should be done thoroughly. Anthropometric, biochemical, and dietary assessment should be done in a very correct way. Anthropometric means we will go into detail in a lot of these aspects, but just to have an umbrella overview, we would need the current weight and their usual weight. Because if their usual weight is, let's say, for example, 80 kilos, and involuntarily this person has lost 10 kilos and currently is 70 kilos, if you do not ask the usual weight, you might lose the opportunity of identifying that this person has been catabolic and has been in a very deteriorating stage, and to help them with this. And it is very common in kidney failure patients who have not yet started dialysis to have a sudden weight loss. It usually has to do with the deterioration of the kidney disease. Biochemical aspects, albumin, prealbumin, and C-reactive protein are very helpful. And with dietary recall, food frequency questionnaire, these are also very important. Now, I would also advocate that non-physician healthcare professionals start doing this screening, because I'm sure physicians do, but I don't think non-physicians do this. And this is such an opportunity to find out a patient who has not yet reached his nephrologist to be screened and taken care of and identified as a kidney failure patient. And it is the urine dipstick. It is a very cheap and affordable and very easy to do test. And we just ask the patient to buy the kit, or even the healthcare professional can have this in their clinic. Any obese, any diabetic, any hypertensive patient who is in your clinic but has not yet reached the nephrologist, it would be good to ask them to do the urine dipstick. As I said, you can have the tool kit in your clinic and ask them to use this. And if they identify a macro albuminuria, which is stage 3 and 4, macro albuminuria, which means already that they have started, macro albuminuria is very equivalent to the stage 1 of kidney disease. If you see this, then it would be important to refer them to the nephrologist, because this would be a good opportunity to find out a patient who didn't know that they are starting in a kidney disease issue, to be referred to the specialist. If it is in the stage 1 microalbuminuria, then what you need to do is control the primary disease, which would be either diabetes, obesity, or hypertension. So this is a good opportunity that I think we would appreciate, and nephrologists would appreciate, if they are referred to these patients. Now, kidney failure has many stages, chronic kidney disease, and the stages could be identified through one of the formulas is the Cockcroft formula. You can see this, and basically, if it is the GFR, the glomerular filtration rate, is anywhere below 90, then the patient is starting to have kidney failure. And if it is below 15, where you see in the left side in the red, then that means that it is end-stage renal disease, and the patient, or stage 5, the renal disease, and the patient needs to go into some kind of a renal replacement therapy, where it could be either hemodialysis, peritoneal dialysis, or a transplant. Now, another thing that one should be very careful about is interdialectic weight gain. Now, this is an issue to take care of for a patient who has started already kidney replacement therapy, which is basically more of the hemodialysis. In hemodialysis, if you know, I'm sure you know, that the patient comes to the dialysis center usually every other day. So let's say Sunday, Tuesday, and Thursday. So between Sunday and Tuesday, they do a dialysis 3 to 4 hours. They go home. They have a 1.5 day that they do not have dialysis. Most dialysis patients do not urinate. So whatever they eat and drink accumulates in their body. So the normal amount of weight, so basically it is liquid weight, yes, that they are allowed to increase in that 1.5 day should not exceed more than 4% of their usual weight. What does this mean? This means that, let's say you have a patient, I'm going to go with 50 kilos because it would be easy to do calculation in your head. If a patient comes 52 kilos on the day of the dialysis, and 2 kilos are removed from him during the dialysis, because those are the excess fluid that have been accumulated in his body, and goes back home with a dry weight of 50 kilos, yes? So that means up to 4% of his body weight that he came at 52 kilos was water, and those 2 kilos were removed, and he went home with 50 kilos dry weight. Next time he comes, this was, let's say, on Sunday. Tuesday he comes with a 52 kilos. That means he has increased 4% of his body weight as liquid. If it is more than 4%, what happens is during dialysis, the physician has to do an ultrafiltration to remove the excess weight. When more than 4% of body weight is removed during the dialysis as fluid, the cardiovascular system has difficulty to adapt, and the patient ends up with hypotension and complications during the dialysis session. So it is very important for the dietetic team, for the team that is managing the nutrition, to encourage the patient not to add more than 4% of their body weight during that time frame that they are at home and eating and drinking. And usually, how does that happen? That happens by advocating, not to encouraging them not to drink too much water. Who is the patient who drinks too much water? When a patient says, I'm thirsty, it's another way of saying, I've eaten too much salt, which has made me thirsty. So you have to be careful and look at this parameter. This is an opportunity for the dietitian to understand, to help the patient find out where are the salty foods in his diet and prevent them, so that the patient comes and doesn't end up adding more than 4% of their weight from fluids between the two sessions. I hope the interdialectic weight gain issue is clear. Malnutrition. Most patients, up to at least 40% of patients with renal failure, are malnourished. When we talk about malnourishment, we should understand that when a patient is malnourished, it means that a patient is at higher risk of poor prognosis of kidney failure, of faster deterioration, and more resistance to the medical treatment that they are being given. A malnourished patient survives less and needs more care and is more costly on the healthcare team to manage. So it is very important to make sure to prevent malnutrition in a dialysis patient or a chronic kidney failure patient. Now, what are the reasons why this patient is so at risk of malnutrition? Any form of dialysis allows losses of protein, but also uremia, which all of these kidney failure patients at any stage live with uremia, increases inflammation, changes the taste in the mouth, decreases the appetite. The increased inflammation increases catabolism. So they have poor appetite, yet they have higher needs because they have catabolism, and the protein that they're eating, they're losing it, a lot of it, up to 0.4 grams per session, per kilo per session in dialysis, in dialysate. So all of these leads to a patient who is malnourished or at risk of being malnourished. Especially dialysis patients, they are overlooked because they are given a high protein diet. So most people think that they are not at risk of malnutrition, which is not the case, because they are being dialyzed, and in the dialysis, they are losing proteins. Now they understand that a renal failure patient at any level of their kidney failure stage, they are at risk of malnutrition. Understanding this is very important. Also, there is something called reverse epidemiology for kidney failure patients. Now, for any patient who is not CKD, having high cholesterol, high BMI, high weight is looked badly. But in kidney failure patients, it's not. Because if a patient has a little bit higher cholesterol, a little bit higher BMI, a little bit higher weight, means they are eating well, means that they are not malnourished. Because a patient, there is something called malnutrition inflammation complex. where malnutrition leads to inflammation and inflammation leads to malnutrition. And if a patient falls into this cycle, it is very difficult to pull them out. So kidney failure patient always has inflammation. That we cannot change, but we can at least change the malnutrition aspect. Protecting the patient from malnutrition is a key role, so that the patient doesn't fall into this vicious circle of malnutrition inflammation complex. And it is a very slippery slope, and the prognosis becomes bad. Also, something that has come out in the past few years is that a patient who does not eat well, who does not meet at least 50% of their caloric needs, ends up with the intestinal barrier, intestinal microflora, intestinal mucus, inner layer of the intestine deteriorating. Once this deteriorates, we have, as you know, good bacteria in the intestine, but those are kept in the intestine, and they're good because they are inside the intestine. They cannot be good if they leak out into the blood. If the mucosa of the gut barrier, of the mucosa of the inside layer of the intestine deteriorates because of poor dietary intake, because of inadequate and low dietary intake, what happens is the good bacteria in the intestine start to leak out into the blood. Once they reach the blood, this causes sepsis, because we do not have good bacteria in the blood. We have good bacteria in the intestine, but we should not have any bacteria in the blood. So making sure that every kidney failure patient, and then in reality, every chronically ill patient eats at least 50% of their needs, it's our fair duty of any healthcare professional. Because as you know, in healthcare, it is first do no harm. And it is important that we do not harm the patient. Now, how do we understand? What are the indicators to understand if the patient is at a risk of malnutrition? If the BMI is less than 23, if the total body fat is less than 10%, if the patient, and this is more easy to identify, has lost 5% of their usual body weight in the past 3 months, or 10% in the 6 months. And you see, the last one is very easy to ask. All you have to do is ask the patient, have you lost weight in the past few months involuntarily? What is your usual body weight and what is your current body weight? And you would identify such an important tool here. Albumin is not so clear, because albumin can be deteriorating because of inflammation. Albumin is not a very clear-cut nutritional indicator. It would be good to look at the other factors, not just albumin. And I would go into the dietary intake from this list. Unintentional low protein intake of 0.8 gram per kilo for more than 2 months, or less than 25 calories per kilo for more than 2 months. So these are very important indicators that any dietitian can check by doing a quick 24-hour recall, finding out how much calories does the person eat, how much protein they eat, and comparing them to the needs. But I again go and emphasize that a quick question of unintentional weight loss is the easiest way to identify if the patient needs your care. Now, a patient with renal failure has these usual symptoms: lethargy, malaise, in Arabic, we say khumul, and headache, weakness, nausea and vomiting, metallic taste, this metallic taste with uremia that comes, that prevents them from eating mainly proteins, loss of appetite, muscle cramps, itching, tingling of extremities. What is the main target diet, overall diet for these patients? It is like a patient who has CVD, cardiovascular disease. For the ones who are more familiar, we call it the therapeutic lifestyle changes, TLC diet, which is low in saturated fat, but not low in fat, and high in fiber. So, and even exercise should be there for kidney failure patients. So the only difference for a kidney failure patient and a cardiac disease patient, the diet is the protein, or else protein and obviously potassium and phosphorus, but everything else is like a cardiac patient, and a bit later you will understand why. So chronic kidney disease, when we are dealing with a patient, the medical nutrition therapy has to focus on a few things. And now you understand how important it is to provide the patient with accurate nutritional therapy, to give enough time for the patient to assess them nutritionally and give them proper nutritional care. We need to take care of the calories, protein, energy, carbohydrate, fluid, electrolyte, vitamin, calcium, phosphorus, potassium, doing all these while making sure that you prevent deficiencies. You provide an attractive and palatable diet. I cannot emphasize more on the last sentence, provide attractive and palatable diet, because very often what happens with these patients is that they are given too many restrictions on their diet. As a result, the patient ends up feeding food. As a result, the patient ends up eating less. We end up having patients that are malnourished, but only because we scared them too much from food. So it is very important to give the diet, to give the correct instructions to the patient so that we give them choices on what to eat, not just what not to eat. Now, what are the protein requirements? When the patient is not yet on dialysis, the dietary protein should be somewhere between 0.8 to 0.75 gram per kilo. When the patient starts with dialysis, with hemodialysis, it is at least 1.2. With peritoneal, it is at least 1.5. Now, unfortunately, sometimes for some unordinary reasons, a patient would be stage 5 kidney failure, but not yet on dialysis. In those specific cases, we might end up, which is where you see this right column, we might end up having less than 0.8 gram per kilo protein, but those are very temporarily. For example, a patient who's stage 5 who is scheduled to have their catheter inserted for hemodialysis, those few days, you might end up giving them a very low protein diet. But do understand that the very low protein diet is very dangerous, and it would be good during this time to supplement the patient with branched chain amino acids. Branched chain amino acids, we have pills of branched chain amino acids and powder of branched chain amino acids. And why I emphasize that is that branched chain amino acids provide nutrition, provide protein to the patient without exhausting the kidney, without exhausting the liver, and without increasing urea in the blood. Now, what about energy? Energy should be given 30 to 35 kilocalories per standard body weight, not ideal body weight, standard body weight. How do we identify standard body weight? Standard body weight, this is a table. Maybe you want to do a screenshot if you're attending this from your laptop. This is an example I will explain to you. To identify the standard body weight, we should have age, we should have frame size, we should have gender, and we should have height. Okay, so let's look at the example that I have highlighted. A female who is less than 55 years old, who is 165 centimeters, and she's medium frame size. Her standard body weight would be 63. This 63 should be used for this energy calculation and for the protein calculation. Now, if you look at this, you can see this a nice way of identifying how to measure the height without making the person stand up. So this is elbow length. Again, if you want, do a screenshot. Through the elbow, yes, the elbow length, just like in the picture, you can identify the height of the person. We call it also ulna length. I'm gonna go, wait, I'm gonna try to find my, yes, here, the mouse. Follow with me with the mouse. This is a female, okay, less than 65 years old. The length of the elbow was 24 centimeters. The height would be 162 centimeters. You see, because most dialysis patients are in the bed when you go. So it's very difficult to take their height. This is a quick way of finding out what is their height from their elbow length. To find out the red is the length of the elbow. And you just have to know the gender and the age of the person. Less than 65. If this person's elbow length was 24, then the height is 162. Sorry. Okay. And frame size can be identified with the wrist. You identify the wrist, you divide it with the height, and you find out what is the frame size. Again, if you want, you can do a screenshot of this. So you need frame size, you need height to find out the standard body weight. Once you have the standard body weight, after that you do your calculations for protein and for energy. Again, I want to show you the standard body weight slide if you want to do a screenshot, and then how to identify the height and the frame size. Now, osteodystrophy. Osteodystrophy is extremely important. It is called the silent killer of kidney failure patients. Unfortunately, often it is asymptomatic. It also causes, if it is symptomatic, it causes pruritus, itching of the skin, muscle cramps, delirium if it is too much, tetany, muscle tetany, and seizures. Now, Keidoki identifies, I don't know if the Zoom bar is blocking. I hope it is. Keidoki clinical practice guidelines for bone metabolism and disease in chronic kidney disease. What do they say? They say that the serum phosphorus should be somewhere between 2.5 and 5 milligram per deciliter. And the calcium phosphorus byproduct, meaning calcium multiplied by phosphorus, should not exceed more than 55. These are the numbers for mainly dialysis patients. You see, the numbers are a little bit different. If you see here below, 2.7 to 4.6 for a non-dialysis patient. Hyperphosphatemia, as one of your colleagues in Riyadh, has been identified as the silent or the hidden killer of chronic disease. Dr. Akram Al-Askar has identified it as the silent killer because very often it is untreated, unidentified, and unfortunately sometimes asymptomatic. The number of times I've seen a patient who has hyperphosphatemia, yet they do not know because the only symptom they have is itching. So they take sometimes antihistamine, anti-allergic drugs, just to make sure that they are they're managing their itch. And whenever you find out such a patient, quickly check their serum phosphorus. Now, why is serum phosphorus such an issue? Serum phosphorus, when it is elevated in the blood, what it does is it binds to calcium. Free calcium that is in the blood binds to this elevated serum phosphorus. Phosphorus is part of the phospholipid membrane of all our tissues, including the vessels. Now, phosphorus is supposed to be in the phospholipid membrane. Only tiny bit of calcium is supposed to be in the phospholipid membrane. But when in the blood, where you have high phosphorus and calcium binds to this high phosphorus, and this bond, calcium phosphorus, goes, so calcium starts going wherever phosphorus is going, but abundant levels of calcium are going wherever phosphorus is going. Phosphorus goes, integrates in the phospholipid membrane of all our organs, and unfortunately, a lot of calcium goes with it. This leads to calcification of most of our soft tissue. This leads to a heart which doesn't pump well because it is calcified, lungs that do not pump well because they're calcified, and cardiovascular system that is not working well because it is calcified. So now you can understand, assume that why hyperphosphatemia can lead to sudden death. Why hyperphosphatemia is called the silent killer. Hyperphosphatemia is a predictable indicator of kidney disease. Most kidney failure patients have hyperphosphatemia, yet it is extremely easy to correct it because it is the only thing that is absolutely managed by diet. Now, diet, phosphate binders, dialysis, and vitamin D. Most physicians do not fail in giving the patient the vitamin D, the proper dialysis, and the proper phosphate binders. But the diet part is where the dietitian needs to take care of. And this is where the multidisciplinary team comes in hand. The dietitian and the physician have to go hand in hand to identify that phosphorus in the diet is an extremely important marker. And the dietitian to understand that they need to check serum phosphorus as an indicator for their dietary management. Now, where is phosphorus found in the diet? It is basically found anywhere in a protein: meat, beans, dairy, seeds. Seeds are a very hidden source of phosphorus. You know, tahini found in a lot of our foods. Sometimes sesame seeds, sumsum, found in breadsticks. Yeah, these are very hidden sunflower seeds. You would have patients who would have understood that they should control most of their phosphorus sources, but somebody forgot to tell them about seeds. They would be eating, bazar, sunflower seeds, and then it would end up having hyperphosphatemia. Whole wheat, not most, but at least 50% of renal failure patients are ex-diabetic patients. When they were diabetic, they were educated to eat whole wheat bread, whole wheat pasta, whole wheat brown rice. But all of these have more phosphorus. So for a kidney failure patient, they should go back to eating white bread, white pasta, white rice. And this is very contradictory to what they've been hearing all their life because before they were diagnosed with kidney failure. And sodas that are high in phosphorus. Now, having said that, we have to be understanding that the explaining the diet well to these patients is extremely important, because when you are explaining, all the patient is hearing is mamnoor, 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 forbidden, forbidden, forbidden. So it is very important to tell them what they are allowed to eat. And this is why it's important to put sufficient amount of time with these patients. Now, as I said, meat, beans, dairy, seeds, whole wheat, and some sodas that are high in phosphoric acid are good sources of phosphorus that we need to control. But that does not mean we should not be giving meat to these patients. They need to eat because they have high protein needs. Now, how to do the balance? The balance is in the following way. As of stage 3, we should be giving these patients two considerations. First, phosphorus that is limited to a maximum of 1,000 milligrams per day. And then another concept. I'll go to the other slide that I think it will be easier for you to see. So the total amount of phosphorus that needs to be given to these patients should be less than 1,000 milligrams per day. But also each protein that needs to be integrated in their diet has to be having this ratio, 10 to 12 milligrams of phosphorus per every gram of protein. Now, this is a bit complicated, I understand. So I need to take a little bit more time to explain. So what you do is you identify what is the amount of phosphorus you want to give to your patient, which should be less than 1,000 milligrams per day, or a maximum 1,000 milligrams per day. On top of this, by the way, this is dietary phosphorus. We are not looking into what comes from the pills. Yes, this is only dietary phosphorus. On top of this, we should be also taking care of the type of protein that we give. Each protein item that we are giving. So this is, the first one was quantity, the second one is quality. Yes, the quality of the protein. Each type of protein that we're choosing should have in it per gram of protein only 10 to 12 milligrams of phosphorus. Now, how do we know this? I'm going to skip this for a minute. I'm going to come to this slide. This is a quick slide, but I have a reference later on I will give you that gives you a longer list of this. That, for example, I'm going to come to milk. Look at milk. Milk in 1 cup, it has in a gram of, I think again, the Zoom bar is blocking your way. Okay, so in 1 milligram, or in 1 gram of protein, how much phosphorus you have? In milk, you have 26 to 30 milligram of phosphorus per gram of protein. Now, what did we say? We say 10 to 12 milligrams of phosphorus to protein. So as a quality, as a food type, milk should not be included in their diet. Nuts, 18 to 24 milligram of phosphorus per gram of protein. Again, something that should not be included in their diet. Yet we come to poultry. Poultry gives you 6.6 to 7.6 milligram of phosphorus to protein. So as a quality, poultry or red meats, which is 8, the ratio, is allowed. So you see through these, here comes fish, yeah, 10 milligram per gram of protein. So through these items, you identify the quality of the food. And then you, from the chosen quality of food, the ones that have the good ratio of phosphorus to protein, what you do is you identify how many grams of those you have to give according to the protein needs. So what do I mean? What I mean is, for example, you decide that you want to give chicken to this patient because chicken, as you see here, it is allowed because the ratio is wonderful, right? The ratio gives you 6.7 milligrams of phosphorus per gram of protein. So the quality as a protein source, chicken looks great. Now, later on, we decide how many grams of chicken we want to give. Now, that depends on the amount of protein you want to give to this patient. And once you decide that, then you calculate how many grams in total of phosphorus you have given to this patient. Sorry, my slides are stuck. Okay, I'm going to go back and see. So again, I want to repeat, I know it's a bit complicated. Phosphorus, 2 things we need to think of. The type of proteins that we're using in the diet. After that, we decide how much phosphorus will accumulate while giving those proteins. Let's say you want to give 50 grams of chicken to this patient and 50 grams of cheese as the protein sources. Now you calculate, cheese is okay because white cheese was okay. You see here, cheese, cottage cheese, for example, which is equivalent to our white cheese, halloumi, akawi, are very similar to the cottage cheese in content of phosphorus, because these cheeses, you know, we boil them. So when you're boiling, you get rid of a lot of the micronutrients. Don't use yellow cheese for kidney failure patients, use white cheese. So cottage cheese is very similar in micronutrient composition to halloumi, akawi, these white cheeses that we have in the Arabic diet. So if you go to that, the ratio is very good. So if you want to give, if you want to bring your proteins to this patient from chicken and white cheese, the quality is okay, very good. That's one check. Then you go to decide how much of them to give so that you don't end up giving more than 1,000 milligrams of phosphorus per day. Now, how do you decide that? You come to this table. I know it's a bit complicated. No one said dietetics is easy. It's a lot of calculations. Now, if you look into this, you see that, for example, again, I'm going to bring my mouse. Yeah, I think you can see my mouse here. Now, for example, meat, yes, one exchange of meat has 50 to 150 milligrams of phosphorus. So if you decided to give 3 exchanges, 3 servings of meat, okay, then you just have to calculate this 3 times 150. I hope that is clear, but it is not within the scope of today's lecture to go too much in depth with the calculations. So I will skip the part of calculations, but if you ever need anything more calculation questions, my email is in this lecture and you are free to email me with your questions. Now, we move along. Oh yes, I wanted to show you with the sunflower seeds. Please look at the sunflower seeds. The ratio is 53 milligrams of phosphorus per every gram of protein. You understand that seeds, how difficult they are for a patient to tolerate. Now, phosphate binders, phosphate chelators. It is very important for the medical team to make the patient understand that phosphate binders, which come and look like as calcium pills, are not what we tell to osteoporosis patients. These are different, the same pills, but they're used for a different purpose. And they should be taken with the meal. Because any patient, you know, if you turn on the TV and you hear about calcium pills and osteoporosis, they say, take them away from the meal, because the aim of that is different. But here, the aim is for the calcium pills, which are phosphate binders, to bind to the phosphorus in the food and remove it in the stool. So it is very important for the patient to understand that these look like the regular osteoporosis pills, but they're used for a different purpose, and they should be taken with the meal. Hyperkalemia. Dr. Ahmad, I hope I am not outside my timeline. Do I have a few more minutes?
5 minutes, inshallah.
Okay, thank you.
Okay, thank you.
Thank you. Hyperkalemia. Hyperkalemia, another thing that I will go very quickly to it. Yes, the needs is 2 to 3 grams per day. I think that's easy to understand, or 2,000 to 3,000 milligrams per day. Now, how do you clarify the potassium needs? This is a good example, I think. We clarify how many milligrams of potassium we gave from the regular foods, meat, dairy, starches. For example, a person's needs is 2,500 milligrams of potassium, and the patient was given this much meat and this much cheese and this much starches. These are the contents of potassium in the food, yes? And let's say the total was 1,400. We calculate how much potassium was used from the foods that are not fruit and vegetable. We identify how much is left. Let's say in this example, 1,100 is left, and then we divide that 1,100 to 2 groups, fruits and vegetables, and we give the rest from fruits and vegetables. When we come to fruits and vegetables, we have many types of fruits and vegetables: low potassium, medium potassium, and high potassium fruits and vegetables. According to this, you decide how many of the low potassium fruits you need to give, medium potassium fruits, and high potassium fruits. Sodium, please look at the slide, sorry. We need to identify how much salt you're giving, and this is a good way of clarifying sodium and salt relationship. Remember, 1 gram of salt has 400 milligrams of sodium, yes? Or 2,400 milligrams of sodium has 1 teaspoon of salt. But please first calculate how much sodium you gave in the diet without salt, and then identify how much salt is allowed to this patient. Now, I want to skip a few slides because I want to tell you 2 more things. Sorry, for time purposes, I want to not lose the opportunity to tell you about exercise. Exercise during dialysis. Patients need to move as much as possible. Exercise during dialysis is not something not to be overlooked. Patients who exercise during dialysis, just like in the picture, have shown to have better adequacy of with the dialysis. Their urine URR has improved. They have started to have a better quality of life. A few years ago, when I used to work in UAE, I conducted the study, effect of an interdialytic exercise. What we did is we provided 45 minutes of exercise pedals during the dialysis, just like in the picture, and the patient's malnutrition improved. This is the reference if you want to go look into it. I also want to share, and this is like a preview of all the needs of dietetic needs for a patient throughout the different levels of kidney failure, if you wish to do a screenshot. And finally, I would like to share a nice finding that says that if a patient is given 2 hours of dietetic care, individualized dietetic care per month, their longevity is improved and their whole life is improved. So it is worth to give that time to these patients. Now, I would like to finally share my last point, which is something that I have developed during my years in the UAE. And it is a mobile dietary app that is unique in its type. And if you wish, later on, I can share the details of the app if you contact me by email. It is a free mobile application, and it is in Arabic, done by a Gulf accent from the patients to the patients. It has educational videos and educational podcasts that helps the dialysis patient identify why is it important to follow their diet? What is phosphorus? What is potassium? Why is a blood test? Why are these blood tests important? And most importantly, we have put around 35 modified recipes that are foods that usually are eaten by the Gulf GCC patient, kidney failure patient, and they are modified in their content so that the patients follow these diets easily and do not feel that they have too many forbidden foods, that they are forbidden from the foods that they like. This way they can share the meal with their family through this knowledge. I suggest that you use this app. It is kilo.ae, mobile application found on Google and Android. It is a free application, and the only aim of it is for patients to benefit, for the dialysis patient to benefit and understand how to improve their healthcare. And its aim is to help the healthcare professional who is working with these patients to improve their dietetic care and their longevity. Thank you so much for your time. I hope I didn't take too much of the time allocated for me. If you have any questions, I'm here by email or later on. And these are good resources for dietetic diet guidelines that you can print and give to your patients. They're free dietetic sources. Thank you very much.
Thank you, Dr. Mireille. It was my pleasure to invite you to our webinar, and we enjoyed your presentation very much, especially myself. It is very nice. I didn't know about this Kila application. It is really nice to have this application. I hope we have a competitor or another version of this app in Saudi Arabia. I think some people will work on it, or already it is there, but I don't know.
But it can be used anywhere. It can be used anywhere.
Really?
Yes, you just have to download it from your Android. I can send you the details. Maybe you can share with the participants.
No, I already downloaded when you shared it. It is Kela, right? Kila.
But .ae, because there's something else with a Kila, yes. Yes, okay. And the name is Kila, Arabic, Kila, but it also stands for something else. It is knowledge for lifestyle improvement.
Yeah, I think here it is, right?
Yes, that's the one.
Okay.
The one.
Yeah. Okay, very good. And I have another question for you. You talk about phosphorus, but maybe I missed some slides or something, but I always tell my patient about the difference between organic phosphorus and inorganic phosphorus, because inorganic phosphorus, as I knew from another presentation for you, if you remember here in Saudi Arabia, inorganic phosphorus has an absorption rate about 100%. And yes, inorganic phosphorus may be 40 to 50%, and inorganic phosphorus is available in all the food preservatives, right?
In processed food, yes. Processed foods. Processed and preserved foods have much more inorganic phosphorus, and unfortunately, yes, it is there. And the balance should be done. Yes, thank you for that observation.
Thank you for your presentation again, and we are sorry that you are awake early in the morning just for us. And...
No, my pleasure.
And now, because of the time, we closed the session of nephrology, and we will skip the presentation for chronic hyperkalemia. I will be making it by the end of the day. And now we will go for the pulmonology session. And we are so happy to invite Dr. Muhammad Al-Ghubain, pulmonology consultant and the head of pulmonology department in King Abdulaziz Medical City. Dr. Muhammad, you are here with us.
السلام عليكم، مساء الخير. ديما دكتور احمد.
وعليكم السلام. سعداء برؤية حضرتك زي كل سنة.
الله يخليك ان شاء الله. Thank you for invitation. Thank you for organizing committee. Thank you for Saudi General Hospital. Thank you for all audience who are they are with us tonight for the last session tonight about pulmonary sessions. I'm going to give two presentations. First presentation about management of acute asthma in the emergency department. And the second session will be third presentation about the management of chronic stable COPD. Can you share the slide with me, please?
Okay, in a minute I will share with you. I'm sorry again. We will start with acute asthma, right?
Yeah, acute asthma first.
Okay. My screen is shared right now, right?
Yeah.
Okay.
Okay. So, thank you, Ahmed. I'm going to talk about first about management of acute asthma, and it's a very important topic because this is it's almost a daily practice in the emergency department everywhere, in a big hospital and small hospital, in small care center or in the tertiary care centers. So as you know, asthma is a very common disease, and at the same time, the asthma presentation, patient with asthma presentation to the ER, it's as you know, that is almost every night, every day. You are going to face a patient with asthma observation, standard of care management of patients with acute asthma observation in the emergency department. The main bulk of my talk is going to be dependent on the Saudi as almost 1 year ago from now, and it was latest edition. Saudi asthma guidelines is basically as a group of asthma experts in Saudi Arabia, and they are part of Saudi Thoracic Society, and they put guidelines about asthma in adults and children's, and part of its chapter about management of acute asthma. So most of this already part of the guidelines. And as you know,
Dr. Muhammad, I'm sorry to interrupt you. Please, because I am sharing from your side and you are talking from the other side. So please tell me next. So I will make the next screen. Okay.
Okay. This is the first slide basically.
Okay. We are in the first slide right now. Okay.
Yeah. This is the first slide. So basically, almost every patient with asthma, regardless if it's a mild, moderate, and severe asthma, that's at risk of exacerbation. So don't look for asthma as patients with severely uncontrolled asthma. They are going to have exacerbation of asthma, while the patient with a mild asthma or they are controlled asthma, they don't have exacerbations. So almost every patient with asthma in all categories or all phenotype of asthma, they're at risk of exacerbations. So even patient with mild asthma, they're at risk of exacerbations. Around 30% of adult patients with acute asthma presentation to the emergency room, they have mild asthma in the previous few months, and even the controlled asthma. So you have to keep in mind that not only patients with the severe asthma, they are going to have acute exacerbation and they come to the ER, even with mild asthma patients. However, a lot of those asthma patients, before they come to the emergency department, they are already relying too much on SABA, short-acting beta agonist, Ventolin, basically, salbutamol. And salbutamol has very high mortality rates and very many adverse effects. So the overuse of the SABA is a very serious sign of the poor control of asthma, and the very poor sign of risking of the patient to have exacerbations, because regular use of the SABA associated with beta receptor downregulations, decrease broncho protections, and rebound hyperresponsiveness. So the more use of the SABA or dependent on SABA, the more high risk of having a rebound hyperresponsiveness, and the more likely to have exacerbations becoming uncontrolled asthma or severe exacerbation of asthma, and increase allergic response and increases airway inflammations. So next slide, please. So the higher use of SABA basically is associated with the first clinical outcome. So it has been in many studies that using more than 3 canisters per year is associated with high risk of emergency department presentations. So almost every patient to the ER with acute asthma exacerbations, they are using SABA at least 1 month, 2 months, 3 months, or even 1 year before their presentations. And the higher the using of canisters, of the number of canisters of the SABA, the more likely to have emergency department presentations. And even the risk of death is very high. Dispensing more than 12 canisters per year is associated with a high risk of death. So it's well known. Data shows that the higher use of canister of SABA, the more likely the patient they may die after they have a sudden death and death of asthma presentation to the emergency departments. So if you see the patient using more than 12 canisters of the SABA, almost monthly using of canister of the salbutamol in the last 1 year, they are high risk of the. So using of the short-acting beta agonist alone and management of asthma is very serious problems and has very high mortality and morbidity. Acute asthma, the previous history of near fatal asthma is very important. Most of the patients with asthma, if they are basically have chronic and controlled asthma, but 30% of them they already have mild asthma. But those who are having chronic and controlled asthma, most of them they have previous history of near fatal asthma, or they're taking 3 or more medications, they are overusing medications, or overuse of SABA, or frequently visitors. Most of those patients already visited maybe last week or 2 weeks or last month, and for several patients, even without admission. So they come to the ER, stay a few hours, discharge, they come next week, the same scenario happens. Eventually, I think they end up to be in the ward or in the ICU. So any patient with acute asthma exacerbation should be assessed to determine the severity of acute attack. So you have to decide the level of the severity of acute attack. So there are 3 levels on initial assessment of acute asthma. Next slide, please. So you have the moderate acute asthma, or severe acute asthma, or life-threatening acute asthma. The moderate acute asthma, basically the patient who has basically talking normally, respiratory rates less than 30, not using oxygen, heart rate is less than 20, oxygen saturation is basically normal, more than 90%, and peak expiratory flow rate is from 50 to 70% of the predicted. So those patients with moderate acute asthma, basically they are talking normal, almost have slight tachypneic, static cardiac, but they have normal oxygen saturations, and the peak expiratory flow rate is 50 to 75% for predicted. It's very, very important for those patients. Any patient present to the emergency department, you have to check the peak expiratory flow rate, and you have to record very well as an initial assessment of the patient to decide if this patient has moderate or severe or life-threatening asthma. For example, life-threatening or severe acute asthma attack, the peak expiratory flow rate is something ranging from 30 to 50%. So usually it's at 50%. Patient usually hypoxic, saturation is at 90%, tachycardic and tachypneic, and using their accessory muscles and unable to complete sentence and agitated. So these patients are able to have severe acute asthma. So they are unable to complete the sentence, agitated, tachypneic, respiratory rate more than 30, using their accessory muscles, tachycardic, heart rate more than 120, and desatting less than 90% enrollment, and the peak expiratory flow rate usually is than 50%. And of course, life-threatening acute asthma exacerbations, they're the extreme part of the disease, which is patient unable to talk, drowsy, comatose, apneic, using extreme muscles, tachycardic, bradycardia, silent chest, severe hypoxemia, saturation less than 90%, cyanosis, CO2 retention, so they have normal or retaining, start to retain CO2, severe acidosis. Those patients life-threatening asthma, which is really need to go to the ICU. So basically, there are three categories of acute asthma. The initial presentation, the first presentation with PR, first 5-10 minutes, you have to decide your patient. Is he having a moderate or severe or life-threatening? And after that, you are going to work according to your classifications. If the patient has an overlap or feature of these things, you have to label him the most severe one. So if the patient has these settings, hypoxia, or oxygen saturation less than 90%, this is severe or life-threatening acute asthma attack. What are medication using in acute asthma? The medication, I'm going to review the medications. We are going to use a management of patient with acute asthma. But always remember, oxygen is the most important thing. Oxygenation is more than important than bronchodilator, more important than steroid, more important than anything else. So the most important thing on patient in management of patient with acute asthma exacerbations or flare up in the ER to maintain oxygen saturation at more than 90%. Okay, either on room air or oxygenation. So oxygen is must as and important. You have to correct hypoxemia by using pulse oximetry or doing ABG, depending on severity of asthma, and your target to keep oxygen saturation more than 90% is a good predictor for the need for hospitalizations. However, very important, the CO2 is very important sign. The CO2, normal or high CO2 is indicating severe attack. If you do blood gas, you find the CO2 is not low, but normal or high. This is pending respiratory arrest and severe attack and needs special consultations. Bronchodilators are very important. Second line of treatment and management of patient in the ER with bronchodilators is inhaled salbutamol, short-acting inhaled salbutamol or phentoline is a drug of choice. You have to give it every 15 to 30 minutes, and usually give the nebulizer continuously 5 milligram per hour. So you can give intermittent nebulizers or continuous nebulizers, or you can give MDI through spacer. This patient's alert, conscious, able to cooperate with you, and he knows what he's doing. So you give through spacer 6 to 12 puff of MDI with spacer, which is usually equivalent to 2.5 milligram of salbutamol by nebulizer. So if you give 1 session nebulizers, is equal to 6 to 12 puff of MDI. So in moderate to severe acute asthma, combination of the ipratropides, so the treatment or LAMA, is you have to you add ipratropium with SABA, with the salbutamol, in patient with moderate and severe acute asthma exacerbations. While the patient with a mild to moderate acute attack of acute asthma, you usually don't need to add ipratropium. So salbutamol is alone is enough. But it's moderate to severe or life-threatening is anticholinergic is very important, was essential actually, part of patient management in this department. So what about magnesium? Magnesium is only not for mild. Next slide. Oh, this slide. Okay. So magnesium usually is not for mild to moderate exacerbation, usually for moderate to severe life-threatening. So it's IV magnesiums, usually 1.2 to 2 gram IV infusion over 20 minutes. It's very safe, very effective, muscle relaxant, bronchodilators effect. So it has it's very safe, and usually it's given for a patient who is not responding to SABA plus LAMA. So together, so you give 2, 3, 4 sessions of SABA and LAMA together. And patient still not recovering, not improving. You add magnesiums 2 gram for 20 minutes. And what about steroid? Steroid is an essential part of in management of patients. Next slide, please. And with acute asthma in the ER. So it's very standard practice that you give steroids in the ER with acute asthma exacerbation, usually that moderate, severe, and life-threatening. Oral IV no difference. So you give oral, unless patient is not able to take orally, he's vomiting, nauseated, drowsy, refusing oral medications and all these things, and you think the patient may not able to swallow it, you give IV steroid. But if the patient able to swallow it and he's conscious, he's not vomiting, and he has an intact stomach, and probably oral prednisone is enough. So usually 40 to 46 milligram, and usually I give, or most of practice, you give 40 milligram single dose of oral prednisone is more than enough in the acute attack, and usually give it within 1 hour of the patient's presentations. Next slide. Intravenous aminophylline nowadays, and the current practice no longer used, is no longer practiced. So people stop using intravenous aminophylline in patients with acute asthma exacerbation because the current management of asthma exacerbation flare-up in the IR is basically more than effective. Bronchodilators, SABA, steroid, magnesiums is more than enough to is more than enough to give those patients. So usually don't give aminophylline in those patients. However, you may use it if you are working in a place which have shortage of facilities, and you don't have a lot of resources, and you don't have some of the bronchodilators, and it's only available in hands, and probably you are allowed to use it. But you're working with the facilities which is all other medication available for you, probably you don't have to use IV aminophylline because it's weak bronchodilator first, and because of the safety issues. We know it's very toxic medications and has a lot of adverse effects, including cardiac arrhythmias, vomiting, seizures, and liver injury. Antibiotic is not routinely used in patients with acute asthma exacerbation because most of the triggering factor of asthma exacerbation usually due to environmental triggering, or because of poor asthma, uncontrolled asthma in the preceding few weeks, or viral infections. So usually not bacterial infections. However, you may give antibiotic if there is evidence of pneumonia or bronchitis or infection, bacterial infection, you may give it. But as a part of routine, antibiotic is not recommended at all in those patients with acute asthma flare-up. So go back to initial management of acute asthma. So in moderate, again, we define what you mean by you define what you mean by moderate. You define what you mean by severe. You define what you mean by life-threatening. And based on your definition and classification, categorize your patient if this patient has moderate or severe or life-threatening. If he is moderate, so the management plan based on these columns or this box, oxygenations is a must. Keep saturations always above 92%. You have to keep oxygen saturation more than 90% of those patients. Salbutamol, either every 20 minutes for 1 hour to 3 sessions, or every 1 to 2 hours according to response, or nebulizers, 2.5 milligram every 24 hours for 1 hour, then every 2 hours according to response. And then you give stacked dose of oral prednisone, 1 milligram per kg, usually 40 to 60 milligram of the oral prednisone. This is for moderate. Okay, for severe acute asthma exacerbations, as I told you, severe asthma, definition of severe asthma attack exacerbations usually is basically peak expiratory flow rate less than 50, patient hypoxic, tachycardic, muscles, and able to complete the sentence. So if you categorize your patient as severe presentations, then management now is basically keep saturation more than 92%. Is a must, is standard. Okay, Salbutamol or SABA should be agonist 2.5 to 5 milligram every 20 minutes for 1 hour. Every 30 seconds according response. Now you add ipratropium bromide 0.5 milligram every 20 minutes as combined with the salbutamol for 1 hour, then every 4 to 6 hours as needed. And now we give oral prednisone 1 milligram up to 50 or 46 milligram as standard oral. And if you're not able to orally for any reasons, give IV steroid. IV steroid usually give IV hydrocortisone 200 milligram or IV hydrocortisone 80 milligram per 24 hours. And now in the severe acute asthma exacerbations, you add magnesiums 2 grams over 20 minutes. And now we have to do a blood gas at chest X-ray, ECG, cardiac enzymes, and look for infection and any other factors. If the patient has life-threatening, acute asthma exacerbation life-threatening, again, the management of this patient, this is a life-threatening conditions. This is basically a critical case. Oxygen saturation is a must. Continuous nebulizations every 10 minutes with the salbutamol plus ipratropium bromide for 4 to 6 hours. IV fluids, hydrocortisone or naltrexone, IV magnesium, then do ABG, ECG, cardiac enzyme, CBC, electrolyte, urea, and ECG. So those patients you have to monitor them very carefully, and you have to be very aggressive in their management, otherwise they don't have complications. So, and then next slide. Then after 2 hours, 2 to 4 hours, you go and evaluate or assess your patient, and you have to assess the adequate response. So what do you mean by adequate response? Adequate response, patient symptom improved, vital sign normalized, peak exposure rate repeated again after 2 to 4 hours, and they find it more than 60, saturation normalized to 90% and above. The patient start to symptom recovered for at least 4 hours, continue bronchodilators for 1 to 4 hours therein, and those patients who has adequate response go back normal to 4 to 6 hours. It's very safe to discharge him home and give him oral prednisone for 7 days. So you make their black for them if they charge on them. Basically, you have to charge oral prednisone for 5 to 7 days. So those patients you have to prescribe them inhaled steroid and inhaled LABA, serotype LABA and LAMA, review techniques and encourage education, adherence, compliance, and all these things. But very, very important, you have to arrange for those patients when they come to the ER with acute flare-up, and you decide to discharge them home after 4 to 6 hours in the management in the ER, and you discharge them with oral prednisone for 5 to 7 days, you have to arrange for them. They should see their physicians, either family medicine or pulmonary clinic within 1 week. Okay, this is important. You have to give them an appointment from the ER to come to their family medicine clinic or pulmonary clinic within 1 week to re-evaluate and assess again and see how they are doing, and they are going to make a long-term performance. Okay, so next slide, please. So this is for the complete response. What about partial response? If you see your patient after 4 hours, 6 hours therapy, and you are a patient in between, he's not completely respond to discharge home, but in between, still more or less minimal improvement in symptoms, symptom-wise 50% better, vital signs stabilized, patient saturation 90%, 92%, but still in oxygen, requiring flow still less than 60%. And those patients have to continue. They may not require admission to hospital, but need more. But they are not ready to be discharged home. Those patients need to keep them in the ER for extra 4 to 6 hours for continuous observation, continuous bronchodilator therapy with beta-agonist ipratropium every 1 to 4 hours, and then after that you have to assist them after 4 hours. So they are almost the total staying in the ER for 8 hours. There's a bunch of responders. So after 8 hours, if they are complete responder, discharging home in safety, but if they are peak flow more than % of liberated, they have normal oxygen saturation, they can go home very safely with the short-term follow plan in the clinic. Okay, I give them oral prednisone and they can be discharged after after 8 hours of observations. So if there is partial, there is no improvement at all. Peak flow, patients not responding to all what they are doing in the ER for them, bronchodilators and all types, steroid, magnesiums, oxygenation, is still requiring high flow oxygen, peak flow poor, fatigue, acidosis. Those patients, these should be admitted to the hospital. You should continue nebulizers, systemic steroid, IC consultations, and possible admissions. Intubations and mechanical ventilations is very common sense, basically. Next slide, please. If the patient please intubate him. Don't be hesitant. Next slide. Okay, so the patient needs to be intubated. Please intubate them, because most of those patients with asthma, if intubated, the bulk of them or majority of them, they are going to be extubated within 24 to 48 hours of admission. So it's usually they're very quick extubator. So don't be hesitant that you are afraid that if you intubate them, it's very between them and no. The moment they are open their airways, it's very easy to extubate them. So the patient has the precautions to protect airways. Patients avoid, of course, don't over sedate them, especially if intubating needs sedation. with them. So don't be hesitant to intubate the patient with severe asthma or life-threatening asthma exacerbations because they're afraid of the potential complication of the ventilators or infection and other factors. So next slide, criteria for admissions. Admission, any patient who has life-threatening attack, clearly the patient needs admission. Life-threatening attack, comatose, decrease of consciousness, CO2 retainers, drowsy, not able to commit sentence, severely hypoxic, and not responding to the first 4 to 8 hours of the initial management in the ER. You have to admit him, still have significant symptoms, still have low peak expected flow rate, usually less than 50 or less than 33% were predicted. If patients frequent ER visitors also probably a reason for admissions. Patient is very concerned about compliance, adherence, poor social support and home support. Pregnant woman who is poor educator and she has life-threatening asthma and need to be admitted to hospital. Patient history of near fatal or brittle asthma probably also need to be admitted to the hospital for further management. So ER preventive interventions in 5 patients high risk. If patient come to the ER, to the ER with acute asthma flare-up, you have to see this patient high risk population or low risk populations. So problem-based care plus asthma management. Okay, and what interventions are feasible in the ED? So what intervention? But nowadays, at least in the secondary care or at least moderate or even the small hospitals, the small centers, most of asthma management is part of the emergency medications, and most of the hospital nowadays, and even small centers and ER departments almost everywhere, is all asthma management or asthma medications already available in emergency departments. So most of the time, it's not a problem to access the medications. So controller initiations, very important. So patients in discharge from the ER, you decide to discharge home, please, you have dischargement, apart from oral prednisone, you have dischargement inhaled corticosteroid, because we know inhaled is standard part of patient management of asthma. So the patient, if you discharge from the ER, they should be discharged at least inhaled corticosteroid. And you have to make a clear plan within 1 week or 10 days at least to see his primary care physician or asthma specialist or pulmonary clinic. So in summary, all asthma patients at risk of having acute flare-up, acute exacerbation, at risk of having ER visit or ER visitations, even the mild controlled asthma. 30% of patients with acute asthma attack coming to the ER, they have a mild asthma, okay? And almost most of patients with asthma, acute asthma exacerbation, present to the emergency department, most of them, they're using SABA before their presentations. Either they buy it or they have it at home, but they are overuser, okay? And this is a very poor predictor for acute attack exacerbations and the high risk of mortality and morbidity. And always cook earlier, to earlier assessment, severe asthma attack, interfere early, the outcome is better. And aggressive treatment initially, when the first 4 hours make a big difference in the patient outcome and management plan. Aggressive bronchodilators, SABA, SAMA, IV magnesium, steroid, and oxygenation standard as part of the standard care of patients with acute asthma exacerbations. If I do response therapy, always you have to think about the patient with life-threatening or severe asthma exacerbation life-threatening. Think about ICU referral. Please call intensivist earlier if you think the patient is pending intubation, pending respiratory arrest or respiratory failure. And you have to make clearly admission and discharge clear criteria and planning for those patients with asthma flare up. Controller educations, again, very, very important, and follow-up is very important to those patients. So in summary, next slide. The best treatment for acute asthma attack is few days before its occurrence. So the patient should have an action plan at home. Action plan. So those patients who are educated about asthma, they know what they are doing. They know how to self-management at home. Basically, this is the best way to minimize the outcome of the patient asthma attack. So most of those patients have a good action. Those patients have an action plan at home. The outcome is completely different from patient who has poor education and they don't know how to deal with asthma intubation if they are outside or if they are away from the hospital. Thank you very much. I did from asthma, acute asthma attack or acute asthma management in the emergency room. I make it very simple, straightforward, very practical, and I hope it was very useful. And all what I brought from for you is come from Saudi Initiative for Asthma Guidelines published last year, and now it's available everywhere in most hospitals, and it's become an officially the official guidelines for Saudi asthma management. Thank you very much.
Thank you, Dr. Muhammad. We have two questions for this presentation. What about the use of azathioprine as an anti-inflammatory? And also about use of epinephrine subcutaneously or inhalation?
Epinephrine for life-threatening patients comatose and respond. You can use it in ambulance and for patients in the ambulance. Or some patients they have home selection, okay, or if in is a response to responding to initial management or the ICU is a must. This is standard practice for sure. For aminophylline, I already about one slide about it. I told you it's no longer used because safety issues, adverse effect, and also because it's weak bronchodilators. And nowadays, SABA, LAMA, magnesium steroid is more than enough to manage patient with acute asthma. So adding aminophylline or aminophylline doesn't add any extra value for patient with acute asthma management. However, you may use it in one conditions. If you are working in a place you don't have any other alternative, so it may save the patient life. I do that. So because you don't have magnesium for injections, you don't have ibuprofen, bromide, and all these things. Okay, so use diaphragm. But if you are working in the hospital with all facilities, all medication around you, this medication, SABA, LAMA, steroid, magnesium is going to do the job.
The other question is about use of potassium chloride as use of beta agonist may cause hypokalemia.
Yeah.
How do you think about this?
Usually, this is in theory true, but in practice, very rare to see it actually. Okay, and usually it's for overusing of the SABA. For a standard dose, regular dose, and even frequent nebulizer, and they usually doesn't happen. But those patients who's using over doses, like if you give patients, for example, instead of giving 2.5 milligram nebulizer, you give, for example, 7.5 or 10 milligram nebulizers, or like 5 sessions, 10 sessions. So it's happening only in overusing of the SABA, but the standard dose of SABA usually doesn't happen. And in practice, most of the time we don't see it. But in theory, it's true. You have to keep it in your mind.
Okay, I think this is the last question. Let me check. It is not clear, but it is about physiotherapy for asthma. If there is a physiotherapy for asthma?
Physiotherapy for asthma?
Yes.
We are talking about acute asthma management in the ER, not in the long-term plan physiotherapy. We have a non-pharmacological treatment for asthma, like acupuncture, physiotherapy, Chinese, herbal, many things. But this is outside the scope of my presentation. This is different topic. This is for acute asthma, this is different.
Okay, so it is clear for us. I will share a screen for the next presentation. It is about the COPD diagnosis and management. Okay, Dr. Muhammad, the screen is yours. We start sharing. Please just make a notice for us.
I thought Dr. Khalid will talk about.
It's okay as you like. But,
I can't talk. I don't mind. I can give my second presentation, but if it's up to you. I'm ready. But Dr. Khalid is okay with him? Or?
Let me see. Dr. Khalid, you are online with us? Dr. Khalid?
Yes.
Hello?
Yes, Dr. Khalid, we are ready to hear your presentation. I thought you're not online about biological treatment of asthma, the future, and severe asthma beyond the science. Is it
Okay.
okay? Okay, I will stop sharing from my side, and you start sharing your screen. And after you finish, we will go back to Dr.
No, I
Muhammad
have to share the screen.
for the second presentation about COPD.
Huh? Okay.
Okay. Everything is okay at your side. There is a green icon. Yes, we start watching your slides, but it is not the first slide.
Huh.
Yes. Okay, Dr. Khalid Hassan, consultant pulmonology, Dalla Hospital. We are happy to see you here.
Thank you very much.
Are coming every year, and we are so grateful that you joined us, despite all the issues you explained before. Okay.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you very much for inviting me to this interesting meeting. Actually, I am here in Egypt in short vacation, so I hope that the internet connection will be okay. And second, and thanks for Dr. Muhammad for this interesting topics about severe asthma. I will complete the management of severe asthma, particularly severe eosinophilic asthma. If we look to the GINA guidelines, we can find that usually step 4 and step 5 are classified as severe or difficult to control asthma, and these patients usually need more invasive intervention. You may use a combination of 3 or more drugs, and we may need oral or systemic steroid, and we may refer to the new medications, which is the biologic therapy in asthma. If we look where we are, or where the asthma, the position or the situation of asthma, we can see that 24% of asthmatics are uncontrolled, usually GINA step 4 and 5. Of these, 17% are difficult to control, and 3.5 are severe asthma. So what is the unmet medical needs in asthma? Despite national and international guidelines, asthma control is not optimal with current standard of care treatment. 5 to 10% of patients have severe asthma that often fails to respond to maximum conventional medical therapy. Large number of hospitalization, more than 500,000 for people with severe asthma every year. Uncontrolled asthma is associated with significant morbidity and mortality and a high economic burden. That's why there is continuous and extensive research trying to properly control the asthmatic patients. 5 to 10% of the total asthma population are classified as severe asthma or uncontrolled asthma or difficult to treat asthma or refractory asthma. Severe asthma, asthma that require treatment with GINA guidelines, step 4 or 5 therapy for the previous year, or asthmatic patients who require more than 50% of corticosteroid in the previous years. Uncontrolled asthma, poor symptom control, frequent severe exacerbation, serious exacerbation, airflow limitation, or worsening of asthma symptoms when the steroid dose is decreased. In the recent years, we have heard about the type 2 inflammation and the eosinophilic phenotypes in asthma. And this is the immunopathogenesis of asthma and the type 2 inflammation in asthma, as seen here in the figures. Exposure to the allergen will be detected by the antigen presenting cells. This antigen presenting cells, after internal processing and the expression of the antigen in combination with major histocompatibility complex class 2 molecule, stimulate a T2 lymphocyte that results in release of various inflammatory cytokines. These cytokines stimulate the B cells to release IgE. The IgE binds to specific receptors on the surface of the mast cells, and on re-exposure to the allergen, antigen antibody reaction occur on the surface of the mast cells with degranulation of the mast cells and release of the preformed inflammatory mediators that results in the early asthmatic attacks. At the same time, the T helper cells release another cytokines that stimulate eosinophilic recruitment, maturation, differentiation, and the infiltration of the airways. The eosinophilic infiltration in the airways results in release of various inflammatory mediators like eosinophilic cationic protein and other mediators that results in smooth muscle contraction, smooth muscle dysfunction, mucus hypersecretion, and the other pathognomonic features of asthma. If we look here to this figure, we will see that the eosinophils are the main inflammatory cells in the pathogenesis of asthma. And that's why the research had focused on the role of eosinophil in asthma and try to target the eosinophil as a therapeutic intervention in asthma management and preventions. Again, or also we can see that the main inflammatory cytokines here in the pathogenesis of asthma is interleukin 5, interleukin 4, and interleukin 13. Interleukin 4 and interleukin 13 stimulate B cells to release IgE. Interleukin 5, interleukin 13 are eosinophilic chemotactic factor that stimulate the eosinophilic maturation and differentiation and even prevent or inhibit apoptosis of eosinophil, and this will result in long survive life for the eosinophils. These are the phenotypes of asthma, either IgE mediated, and it's a biomarker is the IgE level in the blood, eosinophilic asthma, and the biomarkers in the blood and sputum eosinophils, or IgE interleukin 5, or fraction of inhaled nitric oxide, interleukin 13 and the interleukin 4, and we will see that there is higher level of these cytokines in the blood. The non-T2 phenotype is neutrophilic and obesity and these other phenotype of asthma. 50%, nearly 50% of asthmatic patients have eosinophilia or eosinophils present in their sputum, and nearly 50% of acute severe asthma have eosinophils in the airways. The characteristic of eosinophilic asthma can be late onset, equal gender distribution, no or limited allergy to common allergen, risk of severe exacerbation, low FEV1 with persistent airflow limitation, and the most important is the elevated blood eosinophil count, normal or moderately elevated IgE. Other allergic manifestations may be found in eosinophilic asthma, like rhinosinusitis with nasal polyposis, and may be aspirin sensitive, dynamic hyperinflation, and the airway or air trapping. As we mentioned, eosinophils are the most important inflammatory cells in the pathogenesis of asthma, and that's why the biologic therapy is a breakthrough in the management of asthma that target the main inflammatory cell, so in asthmatic patient, and this will results in a portion of the inflammatory cascade, prevent inflammation of the airway and the prevent inflammation in the airways, and so leave the airway free of inflammation, relaxed and dilated. The currently approved biologic therapy for asthma are the first one, Xolair or omalizumab, and this is mainly anti-IgE. Omalizumab is a monoclonal antibodies that binds to circulating IgE in the blood and prevent it from binding to its site on the surface of the mast cells, where eosinophils and the basophils. And this is the main mechanism of the omalizumab. This is the first one and the old one, and this is directed against IgE mediated asthma. The remaining three biologic therapy, mepolizumab, anti-interleukin 5. This one binds to circulating interleukin 5 in the blood. Rislizumab is the same. However, benralizumab or Fasenra is anti-interleukin 5 receptor antagonist, and this one binds to the receptors on the eosinophils. The last one is tupilumab, and this is anti-interleukin 4 receptor. And this, we will come to this one when in a few seconds. So this is the administration, omalizumab or Xolair, Nucala or mepolizumab, Fasenra or benralizumab. All these are available for current use. Here is focus on the role of eosinophil in the airway of asthmatics. So recruitment and the activation of eosinophil in the airways will result in release of various inflammatory cytokines. These inflammatory cytokines will result in desquamation of the airway epithelium, smooth muscle contraction and bronchoconstriction, stimulation of myofibroblast and the deposition of collagen and the fibrin, and smooth muscle hypertrophy and hyperplasia. And if the airway inflammation is not properly treated and not properly controlled, this will result in what is called airway remodeling or fixed airway obstruction. Interleukin 5, granulocyte macrophage colony stimulating factor, interleukin 13, interleukin 4 are the main contributor to eosinophilic activation and subsequent airway inflammation, and all these will result in what is called bronchial hyperreactivity or airway hyperresponsiveness. And if not properly, if this airway inflammation is not controlled, this will result in airway remodeling. If we look to this, we will find that eosinophils is the main cells or the main inflammatory cells responsible for airway inflammation. There are other inflammatory cells, there are other inflammatory mediators, but the major contributor cells in the airway inflammation are the eosinophils. That's why the therapy is targeting to inhibit the eosinophils, to kill the eosinophil, to neutralize the effect, increase the even increase the apoptosis or destruction of the eosinophils, to reduce or decrease the airway or inhibit the airway inflammation in asthmatic patients. Here are two drugs. The first one on the left side is the anti-interleukin 5, and this is the omalizumab Nucala. Nucala is monoclonal antibodies directed against the interleukin 5. It binds to circulating interleukin 5, prevent it from binding to the surface of the eosinophils. The disadvantage of this is eosinophils can be recruited or stimulated from other inflammatory cytokines, and this will result in what's called passive eosinophilic apoptosis. However, the benralizumab or Fasenra is anti-interleukin 5 receptor antagonist, and this binds to the receptor on the surface of the eosinophils and prevent the interleukin 5 from binding its receptor on the surface of eosinophils, and at the same time results in stimulation of the natural killer cell that lead to active apoptosis, and this one lead to more depletion of eosinophil than the anti-interleukin 5. The third drug in current use is dupilumab. Dupilumab block interleukin 5 and the interleukin 13 signaling. And as we know, interleukin 5 and the interleukin 13 play an important role in the inflammatory cascade of asthmatic patient. First of all, they are released from the T helper cells, stimulate P lymphocyte to release IgE that binds to the surface, to receptors on the surface of the mast cells, and at the same time, and this will result in early asthmatic reaction, and at the same time will result in activation, maturation, differentiation of eosinophils, and this will result in type 2 inflammation or what's called the late asthmatic reaction. So dupilumab can block the early and the late asthmatic inflammation. That's why all the previous biologic therapy are indicated if there is high level of, based on the level of eosinophils in the blood, more than 150 or more than 300 cells per cubic milliliter. However, the only biologic therapy that has two indication is the dupilumab or Dupixent. This dupilumab is indicated if there is either high eosinophils in the blood or if there is normal eosinophil, but if the patient is steroid dependent and there is worsening of the asthma when there is tapering of the corticosteroid rule. Dupilumab, if we look here, we can find that the interleukin 4 and the interleukin 13 binds to a shared subunit of the interleukin 4 receptor antagonist. So the so if we block if we block the interleukin-4 receptor alpha, if we block the interleukin-4 receptor alpha, now we can block signaling of interleukin-4 and the interleukin-13 release. And by this unique mechanism, dupilumab can block the release or signaling of interleukin-4 and interleukin-13. Here are some of the studies on the Dupixent or the dupilumab. First, dupilumab significantly reduced severe exacerbation in moderate to severe asthma patient with eosinophil count more than 150. Dupilumab results in improvement in FEV1 within 2 weeks and sustained through 52 weeks. Dupilumab significantly results in reduction in oral corticosteroid, and in more than 50% the patient can use no steroid at all. Dupilumab significantly improved the lung function regardless of the basic eosinophil count. In summary, biologic therapy are promising therapy for future control of asthma if properly indicated, if properly used in the proper position, and this will result in a dramatic control and reduce the prevalence of severe or difficult to control asthma. Thank you very much.
Thank you, Dr. Khalid. It was a nice presentation, and thanks for coming with us this year in our annual webinar. And now we will go to Dr. Mohammed Al-Ghabain again for the second presentation. He will tell us about COPD diagnosis and the management. دكتور خالد استاذن حضرتك بس ستوب شير.
اوكي.
دكتور محمد احنا جاهزين. عملنا شيرنج السلايد. اوكي.
Sure. Yeah. Good evening. Thank you, Dr. Ahmed. And thank you, Dr. Khalid. And thank you for all audience still with us, even evening, night, but the audience, I find it's a good number of people who are listening. And I hope it's going to be interesting at my next talk. Now I'm going to talk about COPD. And before I talk about COPD, a lot of people, they think that COPD is not a common disease. Like everybody knows about asthma. Every physician knows about asthma. But still, COPD, they think that is not as common like asthma. We know asthma is common, like in Saudi Arabia, it's around 10 to 15% of Saudi people have some type of asthma, either mild or moderate to severe. COPD is also a common disease. Either it's common in Saudi Arabia, it's around 4 to 5% of Saudi populations are having COPD. And I think it's maybe more than this, because a lot of those patients, they are not diagnosed and they are not even present in the hospital, because most of those COPD patients, they are asymptomatic, they have no symptoms, or they are preclinical stage, or they have mild mild form of COPD. So COPD is very common disease, and is a 4th leading cause of death worldwide. So it's number 4 worldwide the cause of death. So it's come after cardiovascular, stroke, accident, cancer, and they have COPD. COPD is more common cause of death than chronic liver disease, like kidney disease, like GI disease, like other diseases. So it's basically carry very high mortality and morbidities. And around 6% of all cause of death worldwide is due to COPD. So the previous slide, Dr. Ahmed, السلايد الأول. Okay, first slide. Okay, stop here. So out of all cause of death, COPD death represents 6% of all cause of death. And in the next few years or few decades, expect that COPD burden is going to be increased in our regions comparing with the Western, because we know the risk factor for COPD is smoking, and smoking incidence in the Western population is going down, and smoking incidence in our population is going up, especially nowadays with wide use of the water pipes and public populace and all these things. So it's going to be the COPD incidence in our population is going to be increased in the next maybe two decades. So what's the definition of COPD? Next slide. COPD basically, if you look for this underlying, it's a common disease and preventable. So you can prevent it, you can detect it early, you can prevent it, you can stop the disease from progressions, for complications, and treatable. So there is a lot of moderative treatment nowadays for COPD. So you can treat it, you can control it. The patient with COPD they can live almost normal life with a good treatment, with good management, with good care. So common preventable disease, persistent respiratory symptoms, and airflow limitation. So airflow limitation obstructions, and usually due to exposure to noxious particles or gases, particularly smoking, all type of tobacco products, okay, but other air pollution or biomass and other environmental factors, mainly cigarette smoking or tobacco smoking. So common preventable, treatable, persistent respiratory symptoms and airflow limitation, and alpha abnormalities due to exposures to risk factor or gases, mainly tobacco products. Symptom is dyspnea, cough, and sputum productions, and usually, next slide. Okay, so very important to remember that patients with COPD, when they present to the doctor, the physicians, usually they present when they have symptoms. And the moment they have symptoms, they're having a pre-symptomatic stage or pre-clinical stage for many years and even decades. So most of those patients, early stage of disease, they don't have symptoms. If you do for them lung function or spirometry fundamental obstructions, and they're a smoker, but they have no symptoms or mild symptoms. The moment the patient starts to have dyspnea, short breath and exertions, or previous illness, usually they have basically at least moderate to severe clinical COPD. And for those patients, basically, patient has symptoms, age above 40 or above 50, and exposure history of tobacco products or biomass or fuel exposure. It's very important. COPD is not disease of young or children. COPD disease of middle age and elderly. So it's not like asthma, childhood disease or middle age, but COPD usually middle age and elderly. Symptomatic, cough, sputum, plus risk factor, commonly smoking or tobacco smoking or biomass or environmental or pollution. So to diagnose COPD, you have to have spirometry. So spirometry is required. Okay, so every patient, if you think about the patient, they may have COPD, please order spirometry. And usually the cut limit, the cut value for diagnosed COPD or obstructive or of obstructions is basically FEV1, forced expiratory volume per second, over forced vital capacity, FVC should be less than 70%, 0.7, less than 70%, evidence of the presence of the persistent airflow limitations, and this is post-bronchodilators, not a pre-bronchodilators. So this means not irreversible or not unresponding, so irreversible bronchoconstrictions. FEV1 of FVC less than 70%. And why we treat patients with COPD? Basically, we don't change the outcome, the natural history of disease, we don't change it. But you want to determine the level of, the goal of COPD assessment is basically you want to determine the level of airflow limitations. First, how severe the disease, how severe the airflow limitations. Second, what's the impact of disease in the patient himself or herself. Okay, basically the quality of life. Okay, and third one is risk of future exacerbation or effect, exacerbation, admission, death, ICU, death, etc., etc. This is called the risk of future. So if you see a patient with a COPD, you have to decide the level of the airflow limitations, how much the disease, this quality of life, the impact of the disease, and what his or her risk of the future exacerbation or future events, particularly admission or death. So. Next slide, symptoms, short breath, cough, sputum, Risk factors: tobacco smoke, tobacco, cigarettes, habli babli, shisha, all type, electronic cigarette, every type of cigarettes, basically, all the tobacco products, occupations, indoor air pollution, biomass, age above 40, do spirometry. If you want to offer a FVC ratio less than 70%, post-bronchodilator, this is COPD. So spirometry, as is next slide. So you see, this is basically patient has to blow for 6 seconds, exhale for 6 seconds, and look the relationship between the FEV1 over FVC and the ratio in the left graph, the left figure. Normal ratio is here, for example, FEV1 4 liter, FVC for 5 liter ratio is 80% normal. While the right figure, the right hand, this is a typical obstructive pattern. The previous one here, stop, please, Dr. Ahmed. Here, for example, FEV1 1.8 of the blow for 8 seconds, the patient, his force expired in the first seconds, only 1.8 liter. Force vital capacity is only 3.2. And the ratio in this example is 56%. So this ratio is less than 70%. So this typical examples of obstructive pattern, this typical spirometric feature of COPD. So in this ABCD assessment tool, I'm going to take some time and explain all these boxes, because this is very, very important to understand, because this is to assess. This is called assessment tool. Assessment tool because COPD is heterogeneous disease, not homogeneous disease. So not all patients the same. Not every patient with COPD is mimicking the other patient. It's not like chronic medical disease, like metabolic disease. This is not metabolic disease. So this is a disease which has different phenotypes, different presentations, different heterogeneous disease basically. So either a patient, you can categorize the patient, either a patient in A or B or C or D. It's basically want to assess your patient based on lung function, force expiratory volume in first second. Is a must, as I told you. The ratio post-bronchodilator FEV1 over FVC ratio should be less than 70%. This is a must. Okay, and then you want to see how severe the obstructions. Look to the FEV1, and this is called GOLD. GOLD 1, GOLD 2, GOLD 3, GOLD 4. GOLD 1, if FEV1 ratio more than 80, this is GOLD 1. If it's in between 79%, this is GOLD 2. Anything from 30 to 49% or 50%, from 30 to 50%, this is GOLD 3. Anything in below, if FEV1 below 40% is called GOLD 4. So it's called mild, moderate, severe, and severe, or GOLD 1, GOLD 2, GOLD 3, GOLD 4, depend on the FEV1 percentage of predicted, 80% above, 50 to 79, 30 to 49, or less than 30%. Okay, this is based on spirometry. The other tool assessment is basically on exacerbation tools. It's a number of observations. If the patient had more observation, if has observation 2 or more in the preceding 12 months, this means patient has 2 or more, means patient has severe, at least moderate to severe COPD. So we call him either C or D. Okay, so either patient C or D have had more than 2 or equal to observations in the preceding 12 months. If the patient had no exacerbations, no admission, no air visit, is stable over the preceding 12 months, or maybe 1 mild, moderate exacerbations, the patient either A or B. So you can categorize your patient A, B, C, D based on exacerbation rate. Okay, and the third tool, and also very, very important tool, is basically a symptom-based assessment. Symptom-based assessment, this is quality of life assessment. Quality of assessment, you have to use a tool, and tool is a questionnaire. And questionnaire, you have 2 types of questionnaires. The first one is called MMRCs, Modified Medical Council Research Council questionnaires, and the other one is called CAT, COPD assessment tool. CAT, more practical, more useful, easy, and very simple, and most people use it. Okay, but if you want to use MMRC, if it's the score from 0 to 1 is usually AOC. If you score more than 2 is usually PO or POD. But if you want to use a CAT assessment tool, we have it in Arabic language, validated, available everywhere, and you can give it the patients 10 questions. Patient can score himself, or we can help the patient. Sometimes the patient is illiterate, and if patient score is than 10, means if this patient is than 10 means has a good quality of life. Good quality of life means has minimal symptoms or no symptoms. So those patient has a quality of life was almost normal, minimal symptoms, no symptoms, so label him as A or C. If the patient has symptomatic dyspnea, cough, sputums, okay, fatigue, sleep problems, and all these things, or he's scoring in the CAT score more than or equal to 10 points, okay, so the patient has basically poor quality of life. Either so you label your patient B or D. So if you see a patient first time, you have to categorize him or label him which category. You have to put your patient, he's an A or B or C or D based on two tools. One, exacerbations rate. Two is a symptom assessment tool or quality of life tool. Next slide. Okay. For pharmacology treatment for COPD, there is non-pharmacology treatment, and this is standard of care. Any patient with COPD should receive influenza vaccine, flu vaccine, COVID vaccine, pneumococcal vaccine. All this vaccine is mandatory as essential, and it's must. It's not optional for those patients. As a physician, you have to, okay, to give your patients COVID vaccine, influenza vaccine, and pneumococcal vaccine for any COPD patients. And pulmonary rehabilitation is standard part of nowadays, part of standard of care of patients with COPD, especially if the patient had a category C or D, means symptomatic, means poor quality of life, or severe or moderate to severe. So the patients who have moderate to severe symptomatic, poor quality of life, please send them to pulmonary rehabilitation center. And this is going to improve symptoms, quality of life, and activities. Hypoxia, the patient hypoxic, long-term oxygen therapy is important. Smoking cessation is important. So this is a very important part of comprehensive approach on the management of patients with COPD. Smoking counseling, smoking cessation counseling, long-term oxygenation, pulmonary rehabilitation, and vaccinations for COPD patients. Okay. Next slide. Long-term non-invasive ventilations. You can you put your patient with COPD on home BiPAP. That's what I mean. Long-term non-invasive ventilation, home BiPAP, in selective patients. Is not part of routinely for any patient with COPD. In selective palliative management of patients, you may offer some type of patients with the in-home BiPAP, but not for every patients. Surgical interventions, if patient has severe emphysema, volume reduction surgery, or is very important procedure for patient who have very localized upper lobes emphysema, symptomatic, very advanced. Okay, a poor quality of life, they offer them surgery, volume reduction surgery, and palliative palliative care. And most of those patients, when they end up to having D categories, frequent exacerbations, frequent ICU admissions, frequent requiring for non-invasive ventilation, they are palliative care basically. You have to control their symptoms in advanced COPD. So, next slide. Now, what about inhalers? Pharmacological treatment for COPD. Pharmacology treatment for COPD is very, very important. But overall, in general speaking, pharmacology treatment or all type of inhalers does not change the natural history of disease. Those inhalers available for management of COPD usually to control symptoms, improve quality of life, reduce exacerbations, okay? But the natural history of disease or the mortality or death rate doesn't change, it doesn't prevent them, okay? But we know that home oxygen make difference in death risk or no death risk. Vaccination make difference, okay? But inhalers doesn't make difference, but inhalers are essentials. And inhaler, we have many type of inhalers, okay? But how to decide which is the best inhaler for the best patient? This is called personalized medicine. So what is fit for patient A does not fit for patient B, because as I told you from the beginning, COPD is a heterogeneous disease. Not every patient with COPD mimic the other patients. So every patient is different. Okay, every patient has his own personalized management, personalized therapy, and personalized assessment. Okay, so they are not the same. Okay, so decide what's the best inhalers, what's the best mode of delivery. Okay, depend on the patient's, physicians, technique, educations, resources, cost, and many other factors. But generally speaking, the next slide. Okay, generally speaking, this very crowded slide, but generally speaking from this slide, that the first line for treatment for COPD a pharmacological treatment, COPD usually is bronchodilators, LABA, okay, not inhaled corticosteroids. Inhaled corticosteroids, they are not the first line treatment for COPD. This is completely different from asthma. For asthma, first line treatment for asthma is inhaled corticosteroid. LABA or LAMA in asthma is add-on therapy. While in COPD is the opposite. COPD, first line treatment for COPD is basically bronchodilators, LABA, long-acting beta agonist, or LAMA, long-acting muscarinic receptor or anticholinergic. Inhaled steroid used only in special situation. I'm going to talk about it soon. Okay, but they are not part of routine standard care for patients with COPD. So inhaled steroid is usually not used and generally in most patients with COPD except in special cases. Okay, so because the main treatment for patients with COPD as a pharmacological therapy, as an inhalers, is bronchodilators, LABA therapy. So next slide, please. So as I told you initially, that you have to categorize, assess, and your patient either A or B or C or D, because each category has different treatment options or first-line treatments. Okay, they're different. That's I want to know is patient group A or B or C or D. For example, if patient group A was which means no exacerbations or one exacerbation in the preceding 12 months, or has a good quality of life, almost no symptoms, or asymptomatic, those patients usually preclinical COPD, very mild COPD, early stage COPD, those patients, they require only short-acting beta agonists only. That's it. You don't need to give him a long-term inhaled steroid, no long-term bronchodilator, and all LAMA, all these things. And those patients, you have to counsel very, very early for smoke cessation, influenza vaccination, and all these things, because this is why it's called in the definition of COPD preventable. So if you see patient COPD in category A, that's the best time to prevent any future or long-term complications by the good counseling, okay, and those patients. While group B, those patients has less exacerbations, but they have more symptomatic, so they are dyspnea scale category. There is more in dyspnea, long-term dyspneic in a daily basis, progressive, but they don't have exacerbations. Those patients, first drug choice, okay, usually either LABA or LAMA. So you can put LABA alone or LAMA alone. Group C, now we're talking about patient who has exacerbators. So more exacerbators, but less symptoms. LAMA, first not LABA, okay, anticholinergic, okay, titropiums nowadays called spironolactone, titropium. Okay, so this is a first drug choice for those patients. While group D basically those patients has significant symptoms and frequent exacerbation. So they have 2 or more exacerbations between 12 months. So frequent ER visits, many admissions, very poor quality of life, and home oxygens, the pulmonary hypertensions, okay, and basically those patients have severe COPD. And those patients, you have to put them on triple inhalers, combination of LAMA and ICS, inhaled corticosteroid. This is a consideration of those patients. Okay, so triple now become available nowadays as a single device. So LAMA, and ICS. And next slide, please. So every time you decide to choose the best treatment for your patient, as I told you, it's next slide, Ahmed. Okay, so each time you see your patient and you decide to choose him the best option based on his category A, B, C, D, and you see him later on his follow-up, you have to review, assess, adjust. Review his symptoms, mainly dyspnea or exacerbation, assess the technique of inhalers, inhaler technique, adherence, always think about self-management plans, smoke cessation, vaccinations, pulmonary rehabilitations, and non-pharmacological management of patients with COPD. And then based on this, you have to adjust either in escalate or escalate in the inhaler based on the patient's category. So some patients, they are now in category, for example, B, but after 1 year, they move to C, okay, or C become D, or D become C, or A, B. So that's why you have to just escalate or escalate this management based on the assessment every time. And the assessment every time based on 2 domains. First domain is dyspnea domain, second domain is the exacerbation domain. Okay, so very important to see your patient as a follow-up. Is this patient mainly dyspneic or mainly exacerbators? Okay, so next slide, please. So ICS, inhaled corticosteroid, is not standard routine part as a routine part of patient management of COPD. Most of COPD patients don't need inhaled corticosteroid. This is opposite from asthma. Okay. However, you may consider it in small category of patients of COPD, and usually those patients, usually they are moderate to severe COPD. Those have frequent exacerbators, so many exacerbations, like 2, 3, 4 times exacerbation per year, coming many times in the ER, ICU admissions. Okay, more than 2 exacerbations per year. That's severe COPD. You give them, you add on ICS. If they have asthma with COPD, so overlaps their COPD, but they have some evidence of the airflow reflexibilities or allergic type of asthma-like symptoms, so you add ICS. Or if they have eosinophilia count in the CBC, the peripheral eosinophilia, more than 300, okay, you add ICS. So the ICS strongly supported management of patients with COPD if they have frequent exacerbators, more than 2 moderate exacerbations preceding 12 months, or high eosinophilia count in peripheral eosinophilia more than 300, or they have history of concomitant history of asthma. Okay. Against usage of ICS, if the patient has pneumonia, don't use it for sure. Okay. So if the patient has many pneumonia attack, every time patient comes with exacerbations and it's due to pneumonia, please don't use ICS in patients with COPD, because we know the risk of having ICS has high risk of having this hazard ratio of using of pneumonia and of using ICS. Okay, if the patient has acute myocardial infarctions or recent myocardial infarction or coronary artery diseases, don't use ICS. Or if the patient has eosinophilia count, if they have no eosinophilia or less than 100, ICS is not gonna to work on those patients. Next slide, please. Okay, this is very important. Again, these are domains. Okay, what do you mean by domains? Patient comes for a follow-up, you have to review him, and you have to decide, is your patient mainly dyspneic, okay, and no exacerbations, or mainly exacerbations but minimal dyspnea? Because the approach here is different. If the patient mainly dyspneic, but he doesn't have exacerbation within 12 months, no exacerbation, no visit, nothing at all, but he has dyspneic, he's dyspneic, always dyspneic every time, he cannot walk for long distance, he cannot socialize, poor quality of life, symptomatic, sleeping disturbance, all of these things. If he's using LAMA, okay, together, okay, you may add him ICS, inhaled corticosteroid, if he has concomitant asthma, or if you have a eosinophilia count more than 300, okay, so you may add them. Or in this case, what you'll do if you decide to add ICS, if he's a LAMA alone or LAMA alone, you combine them LAMA together. So if he's a monotherapy, you combine them together. If he's double therapy, okay, you add ICS, triple therapy. So if you are LAMA, if patient LAMA alone, you add LAMA. If he's a LAMA, you add LAMA. If he's a LAMA, and there is a criteria, and his criteria for indication for ICS, you add ICS, LAMA, ICS, and also you have to, if he's dyspneic, you have to investigate for why he's dyspneic, maybe because of other reasons, maybe it's cardiac, core pulmonary, chronic PE, and other pulmonary edema and other things. Okay, just go back here, Dr. Ahmed, go back. Go back, Dr. Ahmed. Previous slide. No, go back. Okay, stop here, please. Okay. Now, the other domain is called exacerbations. So the patient coming with frequent exacerbation, 2 or more in the preceding 12 months, but he's not dyspneic in between. So in between, he has a good quality of life. Okay, what do you do for him? If he's using a LAMA or LAMA, if he's using LAMA, you add LAMA with it, so you're gonna use LAMA plus LAMA. If using LAMA, you add LAMA. Okay. If he's using LAMA or LAMA alone, you add ICS if his eosinophilia count more than 100. Okay, or has frequent exacerbators here, so the exacerbations. Or you add them, and in this case, the patient is going to be on triple therapy, LAMA, ICS. So you see here, ICS, they are more liberal in inhaled corticosteroid in patient with their domain is exacerbation domain, not disease domain. So LAMA ICS nowadays in one device. So long-acting beta agonist, long-acting muscarinic receptors or anticholinergic plus inhaled corticosteroid as triple therapy in one device. Okay, and now you may add. There is many other options called other drug called roflumilast. We don't use it currently except the patient chronic bronchitis, but it's not used anymore. And if patient has a former smoker and still symptomatic frequent exacerbation, severe COPD, frequent exacerbators in triple therapy, okay, and he's ex-smoker, you may consider add for those patients long-term azithromycin, macrolide, azithromycin 3 times per week for at least 6 months. It's going to reduce the rate of exacerbation on those patients. And every time, next slide, please. And every time patient come to you, review, assess, adjust, review symptoms, assess technique and hair, vaccinations, rehabilitation, smoke cessation, etc., need for long-term oxygen therapy, and then adjust, escalate, de-escalate, either going up with inhalers, pharmacotherapy, or decreasing, depend on the category the patient wants. So now in follow-up, you may change the category from A to B, from B to A, from C to D, D, C, and overlap. Okay, and you have to, and patient, you increase. If the patient, for example, gives LAMA, and I say triple therapy, you go back down to double therapy, so you may withdraw and head corticosteroid in this case, or you can you can give double therapy or triple therapy, depending on the assessment, so escalation and escalations. So basically, management of long-term management of COPD based on domains. Okay, what's the domain? Is the dyspnea domain or exacerbation domains? And then you're assessing and reviewing the symptoms, quality of life using the CAT score or assessment score, scoring 10 above and below 10, and then exacerbation rate, categorize your patient A, B, C, D, and then you decide which is the best treatment and where the patient fit, and it should be starting point in that particular category. And then later on, you have to escalate or de-escalate in inhalers, depending on the patient's assessment. Thank you very much. I'm done with the team with management of COPD. I hope it was very useful and very practical and straightforward. I know it's more complicated than this, but I try to make it very simple and very straightforward. But it's very extensive, and I don't go into very detailed, non-practical points. If you have any questions, you are more than welcome.
Thank you, Dr. Muhammad. Let me check the question and answer. It is thanks, comments. No other comment on your presentation except thanks. Thank you. So I am extending the thanks for you, Dr. Muhammad, for the 2 presentations. And now we will go with Dr. Rasha for management of pulmonary embolism.
Thank you.
Assalamu alaikum. And now was the last presentation in pulmonary session with Dr. Rasha Hindi, our SGH Riyadh pulmonary consultant, and she will present us a presentation about pulmonary embolism.
Good evening, everybody. I'm happy to be with you to give a lecture about approach to thrombolytic therapy and managing massive pulmonary embolism. I'm Dr. Rasha Hindi, pulmonology consultant at Saudi German Hospital. Okay. Okay, first we have to know the mechanism of thrombolytic agent. They activate plasminogen to form plasmine, which accelerate lysis of thromboemboli. In thrombolytic therapy is used in patients with acute pulmonary embolism to rapidly dissolve the embolic burden and improve cardiorespiratory hemodynamics. However, thrombolytic therapy is associated with bleeding, which can be catastrophic. Thus, careful patient selection is critical to the success of this therapy. Because the adverse effects of bleeding can be devastating, only compromised patient in whom the diagnosis of acute pulmonary embolism is highly suspected or confirmed, and in whom risk-benefit appears favorable should be considered for thrombolytic therapy. In most patients, the diagnosis is made by CT pulmonary angiography. However, ventilation perfusion scanning or pulmonary angiography, which often immediately precede catheter-directed thrombolytic therapy, may be also confirmatory. Occasionally, thrombolytic therapy is administered when diagnosis is made with bedside echocardiography, when the patient is very unstable to be transmitted from the ICU. Thrombolytic therapy can be administered using an empiric clinical diagnosis during cardiopulmonary resuscitation, but it is rarely successful in refractory pulseless electrical activity arrest. Because the decision to administer thrombolysis is difficult, a multidisciplinary approach that comprises a team of experts, including pulmonologists, cardiologists, thoracic surgeon, interventional radiologist, emergency department physician, and intensivist is needed. Many centers have created pulmonary embolism response team to facilitate rapid diagnosis and management of patients with pulmonary embolism who may be candidate for thrombolysis or other interventions. When making the decision regarding whether, when, and how to administer thrombolytic therapy, most experts consider early involvement of the pulmonary embolism response team. We should evaluate the risk of death from pulmonary embolism and the risk of bleeding from the thrombolytic agents. The importance placed on the risk of bleeding is relative to the strength of indication. As an example, the risk of bleeding from surgical trauma has greater weight if the indication for systemic thrombolytic therapy is, for example, mild right ventricular hypokinesis with normal biomarkers, than if the indication is shock or cardiac arrest. As another example, while a patient with pulmonary embolism-induced shock who is unconscious requiring a very high dosage of vasopressor is likely to benefit from immediate intravenous systemic thrombolytic therapy, the indication is not as apparent in patients who have low blood pressure for 20 minutes, but is awake, alert, and comfortable with low oxygenation requirements. High risk factors in pulmonary embolism that predict prognosis. Number one, persistent hypotension or shock despite adequate resuscitation. Number two, new or worsening right ventricular dysfunction by any one or combination of the following. Echocardiography showing enlarged right ventricle, increased right ventricle to left ventricle ratio, CT showing enlarged right ventricle or increased right ventricle to left ventricular ratio, elevated biomarkers including troponin and BNP, absence of comorbidities that affected the right ventricle function. Number three, and predictors of poor prognosis of pulmonary embolism, a simplified pulmonary embolism severity index more than 0, a high clot burden, more than 70% perfusion defect, proximal deep vena thrombosis in the lower extremities accompanying the pulmonary embolism, significant hypoxemia and or respiratory distress, tachycardia more than 120 beats per minute, poor cardiopulmonary reserve, and presence of right-sided cardiac thrombus. Contraindication to fibrinolytic therapy for acute pulmonary embolism divided into absolute contraindication and relative contraindication. As regarding the absolute contraindications, we have period intracranial hemorrhage, non-structural cerebral vascular lesion, non-malignant intracranial neoplasm, ischemic stroke within 3 months, excluding stroke within 3 hours, suspected aortic dissection, active bleeding or bleeding diathesis excluding menses, significant closed head trauma or facial trauma within 3 months. Relative contraindications, including history of chronic severe poorly controlled hypertension, severe uncontrolled hypertension on presentation, systolic blood pressure more than 180 millimeter mercury, or diastolic blood pressure more than 110 millimeter mercury. History of ischemic stroke more than 3 months, period traumatic or prolonged more than 10 minutes CPR or major surgery less than 3 weeks, recent internal bleeding within 2 to 4 weeks, non-compressible vascular puncture, recent invasive procedures, for streptokinase period exposure more than 5 days ago, or period allergic reaction to these agents. Pregnancy also considered one of the relative contraindications for thrombolytic therapy, plus active peptic ulcer, pericarditis or pericardial fluid, current use of anticoagulant like warfarin that has produced elevated INR more than 1.7 or PT more than 15 seconds. Age more than 75 years old, and diabetic retinopathy, all considered to be relative contraindication for thrombolytic therapy. The thrombolytic therapy may cause moderate bleeding in menstruating women, but it has rarely been associated with major hemorrhage. Therefore, menstruation is not contraindication to thrombolytic therapy. Agents such as aspirin or dual antiplatelet therapy increase the risk of bleeding, but in isolation are not contraindication to thrombolytic therapy. Caution is advised in patients who have had pulmonary embolism induced syncope with resultant head trauma, even if the brain CT showed no hemorrhage. In such cases, the risk of bleeding may be increased due to trauma that may be undetected by head CT. Once the decision is made to proceed with thrombolysis, the clinician needs to decide the optimal mode and timing of administration. While this evaluation is ongoing, patients should be anticoagulated, typically with IV unfractionated heparin. Some patients who experience deterioration from recurrent pulmonary embolism may already be receiving low molecular weight heparin or oral anticoagulant. The optimal anticoagulant is unknown in this population, but switching to unfractionated heparin is not unreasonable. Indications and potential indications for thrombolytic therapy in venous thromboembolism. The first indication and the most acceptable indication is high risk for massive pulmonary embolism, which means presence of hypertension related to pulmonary embolism. Potential indications including patient with severe right ventricular dysfunction due to pulmonary embolism, which call intermediate risk pulmonary embolism. Other indication including presence of severe hypoxemia, patient with acute pulmonary embolism who appear to be decompensating but not yet hypertensive, and extensive clot burden. The clinician should evaluate each individual for any one or more of the following factors that are thought to increase the risk of death from pulmonary embolism. Other than refractory hypertension and shock due to pulmonary embolism in patients with low bleeding risk, none of the listed factors by itself is an absolute indication for thrombolytic therapy. Rather, all other factors are considered collectively so that the risk of death from pulmonary embolism can be assessed appropriately. The simplified pulmonary embolism score index, which one of the prognostic indices, give 1 point for each of the following clinical features. For age more than 80, history of cancer, chronic cardiopulmonary disease, pulse equal or more than 110 per minute, systolic blood pressure less than 100 millimeter mercury, and arterial oxygen saturation less than 90%. Low risk means 0, and high risk mean equal or more than 1. When considering patients for thrombolysis, most expert clinicians use a combination of clinical variables and stratify patients according to the risk of death from pulmonary embolism as high risk, moderate risk, and low risk. Regarding high risk,
we are sorry for this. We will stop sharing and reshape again. Okay. بعطينا رسائل إن السكرين مش واضحة. طيب. Okay. تمام. Okay.
I will be with them. Okay, even if until 10, I will be. Okay. Okay. يعني علقت يعني ما سمعوش نص المحاضرة.
لا هم سامعينك بس السلايدز اللي وقفت السلايدز وقفت. اوكي. لا خلاص تمام. شوف انت وصلتي لفين. اوكي. بتقلب معاك.
When considering patient, I'm sorry for what happened. Inshallah, we will continue again. When considering patients for thrombolysis, most expert clinicians use a combination of clinical variables and stratify patient according to the risk of death as follows. We have high-risk patient, intermediate risk patient, and low-risk patient. Regarding high-risk patient, this category considered hemodynamically unstable. Significant heterogeneity exists among this group, e.g. ranging from marginal hypertension to refractory hypertension, shock, and cardiac arrest. Patients at high risk of death from pulmonary embolism are generally considered good candidates for thrombolytic therapy, assuming that the bleeding risk is low. Okay, the intermediate risk group is the most challenging and is the most heterogeneous. Within this category, significant variation of benefit from thrombolysis is likely. Thus, selecting those most likely to benefit require additional assessment. As a general rule, most experts consider intermediate risk patient as acute pulmonary embolism that is associated with biochemical, echocardiographic, and or imaging evidence of right ventricular dilatation or hypokinesis without systemic hypertension. While not absolute, many patients in this category typically have simplified pulmonary embolism severity index score more than 0. While many patients in this category don't need thrombolysis, a selected group may benefit. So some experts have subdivided this group into intermediate high risk and intermediate low risk categories. Regarding the intermediate low risk category, they are less likely to benefit from the thrombolytic therapy and should simply be anticoagulated in the vast majority of cases, while patients in the intermediate high risk category should be considered for thrombolytic therapy. So we can distinguish intermediate high risk from intermediate low risk as follows. The intermediate low risk group have abnormal right ventricle function or elevated B and B or troponin, while intermediate high risk patients include abnormal right ventricle function and elevated B and B or troponin. Clinical features that should be taken into consideration during this assessment, including evidence of right ventricle dysfunction, may present despite calculated simplified pulmonary embolism severity index of 0, and such patient may potentially benefit from thrombolysis if they meet other high-risk criteria. Certain older patients or those with underlying cardiac disease or on beta blockers may have inappropriately low heart rate response to the stress of pulmonary embolism. Some patients with acute pulmonary embolism may have an oxygen saturation of more than 90% at the rest, but desaturate significantly with exertion, even sitting up in bed or having postural hypotension. And these features are not accounted for in the simplified pulmonary embolism severity index. While patients with extensive clot burden have been defined by some groups as moderate pulmonary embolism, this definition is not consistent in the medical literature, and not every patient with extensive clot burden has right ventricle dysfunction or needs thrombolysis. As patients with a simplified pulmonary embolism severity index more than 1 also meet the definition for intermediate risk pulmonary embolism, such patients must have abnormal right ventricle function and elevated BNP or troponin before considering thrombolytic therapy. Low-risk patients not require thrombolytic therapy and should be treated with anticoagulation alone. In most patients, thrombolytic therapy is administered immediately when the indication is clear, like shock due to pulmonary embolism. However, in some cases, when the indication is uncertain, like intermediate risk pulmonary embolism, some experts observe the response to anticoagulation during the first 24 hours following the diagnosis. If during that time the patient improves, don't proceed with thrombolytic therapy. In contrast, during this period, the patient have persistent or worsening signs of distress like severe tachycardia, borderline blood pressure, poor oxygenation, you may need to proceed with thrombolytic therapy, since the benefits likely outweigh the risk at that point. Once it is decided that thrombolytic therapy is indicated, we should decide the method of administration, the dosing, the intravenous or infusion or bolus. And these decisions depending upon factors including hemodynamic instability, risk of bleeding, available expertise, oxygen requirements, and extent of the emboli. Regarding the hemodynamically unstable patient, high-risk patient, in this group with low bleeding risk, the only widely accepted indication for full dose systemic thrombolysis is acute pulmonary embolism causing shock or persistent hypotension, which means systolic blood pressure less than 90 millimeter mercury, need for vasopressor, or decrease in the systolic blood pressure bar by 4 millimeter mercury or more from baseline for 15 minutes or longer despite resuscitation. Systemic thrombolytic therapy leads to early and rapid hemodynamic improvement, which include improvement in pulmonary artery blood pressure, right ventricular function, and pulmonary perfusion. However, a clear mortality benefit or reduction in pulmonary embolism recurrence has not been clearly proven. Regardless, most experts believe that benefit of rapid resolution of emboli causing shock or near shock is sufficient to justify thrombolytic therapy despite the increased risk of major or even catastrophic bleeding. In patients at moderate or high risk of bleeding who are unstable due to pulmonary embolism, guidelines suggest catheter-directed therapies like ultrasound, saline, rotational device, or suction, with or without thrombolysis rather than full-dose systemic thrombolytic therapy. Sometimes reduced dose systemic thrombolysis may be alternative if catheter-directed approaches are unavailable. While patients in this category may not ideal for any of the thrombolytic therapies, some experts administer catheter-directed thrombolysis when the benefit is believed to outweigh the risk, like life-threatening unstable pulmonary embolism in patients with minor fracture or compressible surgical wound. Catheter-based therapies are also an option for those in whom systemic thrombolysis fail, provided the necessary local expertise is available. A patient with hemodynamically unstable pulmonary embolism in whom thrombolysis is contraindicated, surgical or catheter-directed embolectomy are options. While American College of Chest Physicians supported the administration of catheter-directed therapies with or without thrombolysis as an option in hemodynamically unstable patient in whom death is likely to occur before systemic thrombolysis can manifest effectiveness within hours, other experts believe that implementing systemic thrombolysis, even the latter, over 2 hours is in fact nearly always faster than catheter-directed approaches. Extracorporeal membrane oxygenation is a useful adjunct for supporting patients with refractory shock or hypoxemia from pulmonary embolism. Regarding the full dose thrombolytic therapy in hemodynamically unstable patient, experts prefer systemic thrombolysis with typically tissue type plasminogen activator. This preference is based upon the widespread availability and the clinical experience with this agent, as well as the rapidity with which it can be administered in life-threatening situation. Intravenous access need to be secured and central access not required. Necessary invasive procedures like intubation and IV access should be quickly performed while infusion is being prepared, and all other invasive procedures delayed until after infusion is complete. It is preferred that a specialist in anesthesia perform intubation in these patients, if possible, since a sudden increase in the pressure from intubation and mechanical ventilation and hypotension from sedatives may have significant adverse effects of already compromised right ventricle and precipitate right ventricle shock. Full dose IV thrombolytic infusion regimen are the most common method of administering these agents. We have recombinant tissue plasminogen activator and streptokinase. No agent has proven to be superior, and this coupled especially tissue plasminogen activator we chose because shorter duration of infusion time in cases of acute pulmonary embolism. FDA approved using regimen for IV tissue plasminogen activator alteplase is 100 milligram administered over 2 hours. In more urgent situations like impending cardiac arrest, it is appropriate to administer tissue plasminogen activator as a bolus as infusion over 15 minutes, or as 20 milligram IV bolus followed by infusion of 80 milligram over the next 2 hours. Fullest infusion of thrombolytic therapy is indicated for patients with pulmonary embolism-related cardiac arrest. During the infusion, the patient should be monitored closely for stability or improvement of the vital signs and oxygenation, the development of neurological signs, hemodynamic or obvious signs of bleeding. Generally, clinical improvement is noted within the first hour of infusion. When infusion of thrombolytic agent is complete, IV unfractionated heparin should be restarted. Minor bleeding during thrombolytic therapy is common and not generally an indication to stop therapy. And this minor bleeding may occur at sites of invasive procedure like the veiny puncture or arterial puncture site or in the skin and the gums. The bleeding from vascular site should be controlled with manual compression followed by pressure dressing. Many experts also tolerate bleeding from menstruation and bleeding control at compressible sites like epistaxis and walls. Minor bleeding from GIT or genitourinary tract may also manage it by following clinically by vital signs in hemoglobin. However, signs of major bleeding are indications to immediately stop the infusion and treat the bleeding. These include hemodynamic compromise, mental status changes, significant reduction in hemoglobin by 1 to 2 grams per deciliter, need for transfusion, and copious amount of bleeding. If intracranial bleeding is suspected, clinical infusion of thrombolytic agent should be immediately discontinued. Following stabilization and contrast-enhanced CT scan of the brain, an emergent neurologic and neurosurgical consultation should be obtained. If the patient continues to have significant or refractory bleeding despite cessation of thrombolytic agent, transfusion with 10 units of cryoprecipitate with or without 2 units of fresh frozen plasma, and then reassess. In addition, protamine sulfate should be considered to reverse the effect of any heparin that may remain in the patient plasma. When considering reversal, the relative severity of bleeding and the thromboembolic process must be weighed in view of potential to exacerbate the thrombosis again. Following thrombolysis, patients should be fully anticoagulated with IV unfractionated heparin. Avoid initiating longer-acting anticoagulant like low molecular weight heparin, an oral agent like direct oral anticoagulant and warfarin for at least 24 hours to ensure that there is no delayed bleeding that would require immediate cessation of anticoagulation. After the thrombolytic infusion is complete, start heparin infusion without a bolus. However, to minimize the risk of bleeding, we check activated partial thromboplastin time and use some unfractionated heparin without loading dose when the activated partial thromboplastin time is less than twice its upper limit of normal. If BTT exceeds this value, we repeat it every 4 hours until it is less than twice its upper limit of normal, at which time we can resume heparin infusion. Once stable for 24 to 48 hours, patients should be transitioned to an oral agent like direct oral anticoagulant or warfarin, and the duration of long-term anticoagulation following thrombolysis is generally the same as for patients who are not receiving thrombolytic agent. The pulmonary hemodynamic improvement following thrombolytic therapy include improvement in pulmonary arterial blood pressure, right ventricle function, and pulmonary perfusion more quickly than heparin alone. Improvement generally occurs over the first several days, however, it's uncertain whether beneficial effects are persistent. Thrombolytic therapy has been shown in several meta-analyses of a patient with acute pulmonary embolism to improve mortality at the expense of increased rate of bleeding. A meta-analysis of 16 trials reported reduced rates of recurrent thromboembolism with thrombolytic therapy compared with anticoagulation alone. However, recurrence rate were assessed at varying time points and confidence interval were wide, suggesting variability in this effect. Patients should be monitored for continued signs of improvement like reduced heart rate, respiratory rate, and improved oxygenation and blood pressure following the infusion. Generally, clinical improvement may continue for a few hours and days beyond the completion of infusion. Although not routine, many experts also perform echocardiography 24 hours following infusion to examine the size and function of the right ventricle. While many cases demonstrate improved right ventricle size function, right ventricle recovery may lag behind the clinical improvement. We have to talk about catheter-directed approaches. Thrombolytic agents can be infused directly into the pulmonary artery via pulmonary arterial catheter, which means catheter-directed thrombolysis, which has also potential advantage that lower the dose of lytic agent, which can be administered, and so reducing the risk of bleeding compared with systemic therapy. Clot removal also performed using catheter-directed approaches like mechanical ultrasound or jet saline lysis. Both thrombolysis and clot removal can be performed in isolation or in combination. Typical access sites are internal jugular and femoral veins. Guidelines suggest that catheter-directed approaches are options for patients with persistent hemodynamic instability despite systemic thrombolysis, and those with hemodynamic instability due to pulmonary embolism who are at moderate or high risk of bleeding. Importantly, catheter-directed techniques should be reserved for use in centers with appropriate expertise, since they are also without risks. Further hemodynamic instability can occur, bleeding at the insertion sites, and arrhythmias all can occur. The following are situations in which some experts typically use the thrombolysis in hemodynamically stable patients with pulmonary embolism. We have two situations: intermediate high-risk pulmonary embolism, which previously known as submassive pulmonary embolism. The other situation, patient with acute pulmonary embolism who are clearly deteriorating but not hypotensive. As regarding the first situation, it is defined as intermediate high-risk pulmonary embolism, defined as right ventricular dysfunction, together with an elevated troponin or prenatrient peptide, particularly when there are other supportive findings such as significant tachycardia, severe hypoxemia, respiratory distress, and extensive blood burden. The second situation, as we told, patients with acute pulmonary embolism who are clearly deteriorating but not yet hypotensive, which means showing signs of failing anticoagulation. Patient with intermediate high risk patient may benefit from thrombolysis, and the rationale for thrombolysis in this population based on the observation that severe right ventricle dysfunction is associated with a worse prognosis than mild or no right ventricle dysfunction. However, randomized trials have not shown convincing or consistent mortality benefit from thrombolytic therapy in patients with right ventricle dysfunction. For those in whom thrombolytic therapy is selected, it is suggested that catheter-directed techniques rather than systemic therapy, provided the expertise is available and the bleeding risk is low. Full-dose systemic thrombolytic is a suitable alternative if the local expertise is not available, or if the patient not suitable or cannot transfer. While there are relatively few data, reduced dose systemic tissue plasminogen activator may be also a reasonable option when catheter-directed thrombolysis is not available. Patients who don't improve or deteriorate despite anticoagulation may consider for thrombolysis, either systemic or catheter-directed, an indication that's supported by guidelines. Patients assessed to have high blood burden and or severe hypoxemia are sometimes considered for thrombolysis, particularly when these features are combined with high risk factors from death from pulmonary embolism. The mode of administration is preferably catheter-directed thrombolysis based on the same rationale as for those with intermediate high risk. The last item we have to talk, the bleeding risk among studies due to thrombolytic therapy. The rates of major bleeding range from 10 to 20% of systemic agent, while low rates in the region of 4% of less or less have been reported for catheter-directed thrombolysis. 2 to 5% may experience intracranial hemorrhage with systemic agent, while rates of less than 1% are reported in those who receive catheter-directed thrombolysis. And this is the last issue I talked about thrombolytic therapy in pulmonary embolism. Thank you so much. If any...
Thank you, Dr. Rasha. And we give him anticoagulation. Then he becomes shocked and mechanical ventilation. Is there an indication for thrombolytic therapy at that time?
Sure. Sure. At that time, one of the indication to thrombolytic therapy, if already I give the patient the anticoagulant and then progressively failed anticoagulation, I mentioned this before. If failed the anticoagulation, we have to give thrombolytic therapy.
And there is increased bleeding risk from anticoagulation and we give thrombolytic therapy. There is increased bleeding risk.
This is an emergency. We have to give an emergency. Always we weigh between the risk and the benefit. It is a life saving. Yes. The anticoagulation by itself is not contraindication. We, by the way, we have to start IV unfractionated heparin while we are preparing the thrombolytic therapy. So we have to start before the thrombolytic therapy.
Thanks for Dr. Rasha. In a minute. Thanks everyone for staying with us till now, and we thank Dr. Rasha for giving this valuable presentation and answering the question. I received many questions in the question and answer session about Mr. Tamer. Okay, Mr. Tamer is working 24/7, okay, but he has the right to relax for a few minutes. Just give him a few minutes, and within 1 hour, he will answer all the questions regarding registration and the CME hours, okay? He's answering everyone, and he will let you join the group for all the questions about this presentation. And now, I will have a quick review about hyperkalemia. I will start the presentation now, and if we didn't finish, I will continue tomorrow, okay? Okay, I will be talking about management of chronic hyperkalemia. We all know all about electrolytes in our patients. We deal with patients all the time, and every now and then we are ordering serum electrolytes, whether sodium or potassium. That's why we have two presentations in this webinar about hyperkalemia and hyponatremia. I will give a brief introduction about hyperkalemia and how to manage and what is the importance of hyperkalemia. And also, I will continue the management tomorrow for the time factor we suffer from now. Potassium is a major intracellular cation with 98% of the total pool being located in the cells, with a concentration of around 140 to 150 millimole per liter, just resembling the serum sodium, okay? But the potassium is mostly intracellular, and only 2% of potassium is extracellular, where it ranges in the blood from 3.5 to 5. And a fine regulation between intracellular and extracellular gradient is crucial for life. We all know that hyperkalemia may cause fatal consequences by affecting the heart conduction. Here, a brief about potassium homeostasis. The kidney is the major regulator. If you can follow my arrow here, how we lose potassium out of the body. The intake is fixed and the output should be fixed also to keep the balance. Here, the intracellular fluid potassium is about 3,600 millimole and the extracellular fluid is 55 millimole. How we lose? We lose every day from 20 to 100 millimole per day in the urine and only 5 millimole per day in the feces. And here, loss of potassium in the feces will be the target of some of the drugs we will talk about today. So the balance will be balanced by managing the intake, whether it is high or low, and the redistribution between intracellular and extracellular fluid, working on hormones and acid-base balance, and the output, whether through the urine or through the gut. Here is the hormonal balance that controls potassium through the kidney. Here's the glomerulus, proximal convoluted tubules, lobe of Henle, distal convoluted tubules, and afferent and juxtaglomerular cells, which makes the juxtaglomerular apparatus and collecting ducts. If we will have here impaired release of renin, we are affected here by the renin, angiotensin, aldosterone system. If there is affection of renin release by using non-steroidal beta blocker, cyclosporine, tacrolimus, or having long-standing diabetes or in elderly patient, there will be affection in renin. Using renin inhibitor, direct renin inhibitor like aliskiren will affect the production of angiotensin 1. Using angiotensin converting enzyme inhibitor or ARBs, which is angiotensin receptor blocker, will affect the release of angiotensin and also will cause hyperkalemia. In the same time, impaired release of aldosterone by adrenal disease using heparin or ketoconazole, which is antifungal, or using aldosterone receptor blocker like spironolactone and ipilimumab will cause hyperkalemia. Also, a sodium channel blocker like amyloid and trimethylene will make the same effect through the sodium-potassium channel in collecting ducts. So, affection of any step here will cause hyperkalemia by reducing the urine loss of potassium. But what is the functions of potassium in the body? Potassium is very important for cellular homeostasis, for the heart function, skeletal muscle and smooth muscle contraction, nerve impulse transmission, and also enzyme function and protein synthesis and DNA synthesis. Hyperkalemia is defined as any serum potassium above 5. Above 5 to 5.5, it is mild, 5.5 to 6, moderate, and above 6, it is severe. There is some difficulties in diagnosing hyperkalemia because it is not like ischemic heart disease or cerebrovascular stroke. It has asymptomatic and non-specific presentations. like fatigue, weakness, muscle twitches, palpitation, GI abnormality, cardiac abnormality, and the neurological abnormalities. And even these symptoms may vary from patient to a patient. Affection of the potassium of the ECG is evident, but can we depend on ECG to diagnose hyperkalemia? We will see now. Here is the normokalemia ECG. With hyperkalemia, you can see there is elevation of the T to be tinted T wave with prolongation of BR interval and depression of the ST segment, and at the end, it can end into ventricular fibrillation, asystole, and sine wave pattern, which is fatal. But again, the question, can we use ECG to diagnose hyperkalemia? The answer is no, because some hyperkalemic features may not affect the heart. It is individual variation. Some people may present with fatal arrhythmia, but they don't have this high potassium level like others. Elevated potassium is associated with increased all-cause mortality, whether hypokalemia or hyperkalemia. It is silent killer. Please follow my arrow here. Here is the predicted probability of mortality from 0 up to 1. And here is the comorbidities. And on the baseline here, there is the serum potassium. If we have low potassium with control group, diabetes, chronic kidney disease, heart failure, or chronic kidney disease, heart failure, diabetes, you can see on the extremes of the lines with hyperkalemia or hypokalemia and increase the comorbidity, all-cause mortality will be higher. So affection of the potassium level, whether high or low, will affect the mortality. Also, hyperkalemia is the leading risk for mortality for the inpatient for patient with heart failure. You can see here systolic blood pressure, age, heart rate, ischemic heart disease, all these causes can cause mortality. But just potassium, more than 5.5 is the leading cause with risk hazard ratio of 4, which is very high in comparison with other hazard risk for other factors. The others are all less than 2. There is a risk of hyperkalemia recurrence. It is very high risk. People who may suffer from hyperkalemia one time have the chance of having 50% recurrence. Some people may suffer from more than 20 recurrent episodes within 1 year. And the prevalence of hyperkalemia in chronic kidney disease ranges from 40 to 65% of patients with CKD. And even in some specialized clinic may reach up to 55, even with diet control and medical control. And the annual mortality may reach up to 25%. These are the causes of hyperkalemia: pseudo-hyperkalemia with delayed sample processing, with tourniquet for longer time, severe leukocytosis and thrombocytosis, and hemolysis. Also the iatrogenic, I discussed it before, with all stations affecting the renin release, angiotensin release, angiotensin converting enzyme, and working on aldosterone release or aldosterone receptors. Diabetic ketoacidosis, cellular lysis, and renal failure, and also type 4 renal tubular acidosis. I just put this slide to let you see how much potassium is everywhere. It is in most of the fruits, most of the vegetables, and other products. But it ranges from high concentration to lower concentration, and we all know that dates and the banana contains the highest concentrations of potassium. But I am talking about iatrogenic hyperkalemia. Why should we use ACE inhibitors, medications that is depending on RASi blockade, like it is renin, angiotensin, aldosterone system inhibitors? It may be renin inhibitor, direct renin inhibitor like aliskiren, maybe ARBs or ACE inhibitors, maybe spironolactone, which is aldosterone receptor blocker. Why we have to use this medication in heart failure and chronic kidney disease? As you see in these studies, HOPE study and SOLVIT for ACE inhibitor, ACE inhibitors managed to reduce the combined outcome for MI, stroke, cardiovascular mortality by 25%, which is very significant. And also 16% reduction in heart failure related hospital admission and mortality in patients with congestive heart failure. And the ARBS in CHARM and IDENT and the Renal study managed to do the same, reduce the mortality and reduce the morbidities and the hospital admission. And also mineralocorticoid receptor agonist in RALS and the emphasis managed to reduce the mortality and morbidities in the same patient population. And in these studies, we can see here the hyperkalemia rate. If you follow the arrow here, the hyperkalemia rate ranging from 38% to 12% of significant hyperkalemia in all the mega studies for using medication working on the RASI system. And all those patients have to reduce or stop the RASI, and in the same time, we will lose the benefits of the RASI blockade I discussed before. So now the unmet need, what is the unmet need? I want to raise this question now and answer tomorrow. RASI is associated with a better clinical outcome. We cannot deny this fact. Some patients like chronic kidney disease, proteinuric patient, heart failure patient, ischemic heart patient cannot go without RASI blockade. And in the same time, physician and patients have to down titrate or stop RASI because of hyperkalemia. Stopping RASI because of hyperkalemia may worsen the patient outcome, or we are sure that the patient outcome will be worsened. So we have to work on medications that will reduce the potassium and allow us to use RASI blockade. And management of chronic hyperkalemia, tomorrow I will talk about potassium binder, namely zirconium cyclosilicate and batiromere, plus the conventional known potassium binders for all of us like calcium resonia. Thank you for today. And tomorrow we will continue this presentation, but because of the time factor, we cannot continue. If I will stay and I started this subject, we will stay till maybe 10 o'clock this evening. I am very happy that all of you are still here since the beginning at 4 o'clock, and waiting for you tomorrow in the same time from 4 to 9 to continue talking about hyperkalemia in the nephrology session tomorrow and miscellaneous subjects in the last session tomorrow. Thanks for all and goodbye. Last question, if everyone is here. Management of hyperkalemia, I will discuss tomorrow. Some doctors are asking about use of insulin. We will answer this question tomorrow. Thanks for all.